room for other people as they arrive. Distinguished guests, esteemed faculty members, ladies and gentlemen, it is with great honor and privilege that I welcome you to the 52nd Annual Symposium and the 41st Journal launch of the Dokita Editorial Board. Today's gathering stands as a testament to our collective commitment to advancing knowledge and addressing critical issues in healthcare. This year's theme, Contemporary Threats to Nigeria's Public Health, Infectious Diseases, Flooding, and Research Funding Deficits, highlights some of the most pressing challenges confronting our nation. It is a call to action, an opportunity to reflect, discuss, and propose solutions that are both timely and necessary. We are deeply honored to have in attendance dignitaries from the University of Ibadan, dignitaries from the College of Medicine, University in Ibadan, distinguished members of faculty, our invited special guests, esteemed medical professionals, and our future, the students. Your presence here underscores the importance of this dialogue and the shared responsibility we all carry in safeguarding public health. On behalf of the organizing committee, I extend my sincere gratitude for your participation as we celebrate not only the launch of this journal, but also the rigorous research, intellectual contributions, and the collaborative spirit that fuel progress in these uncertain times. Without further ado, let us commence today's proceedings with the dignity, focus, and excellence that this occasion demands. Thank you. Now, thank you very much. I would like to call Mr. Yusuf Emmanuel of the Dokita Editorial Board to open for us with the opening prayer.
Good morning, everyone. Let's all rise up as we pray. Our Heavenly Father, we thank you. We appreciate your holy name. Bless you for this wonderful day that you have made. Thank you for giving us the opportunity to see this day. Let your name be exalted in Jesus' name. Oh Lord, as we want to start this program now, we pray that you start with us in Jesus' name. This program shall go on smoothly and there shall not be any form of distractions in Jesus' name. And we pray that we shall end this program well in Jesus' name. Thank you for answering our prayers. In Jesus' mighty name we have prayed. Thank you very much.
Thank you very much. Please let's keep standing as we listen and we revere the national anthem.
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign fatherland. Our flag shall be a symbol that truth and justice reign. In peace or battle honored, and this we count as gain. To hang on to our children a banner without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed. And so with peace and plenty, Nigeria may be blessed.
And now the college anthem.
Keep the
Thank you very much. We may all be seated. I would like to use this opportunity to welcome and recognize academic royalty in our midst, our special dignitaries here today, our guests of honor, and I would like to ask you to enjoin you to appreciate them with a round of applause as I call them to the high table. We have in our midst the symposium chairman, Professor T.O. Alonge. Good morning, sir. Welcome. Please, we'd like you to join us on the high table. We have the provost of the College of Medicine, University of Ibadan, as well as the vice chancellor of the University of Ibadan, ably represented here by Professor Ogbole. Welcome, sir. Thank you very much. Please join us on the high table. The Chief Medical Director of the University College Hospital, ably represented by Professor Olawe. We have in our midst the Dokita Board Chairman, Professor Akinka Omigbodun. Good morning, sir. Welcome. I'd like to invite Dr. Jokotade Adeleye to the high table. Welcome, ma'am. The Commissioner of Health for Oyo State, Dr. Oluwaseremi Ajetumobi, who is currently in absentia but will be joining us soon. I'd like to invite our speakers this morning, Dr. Olukemi Adekombi of the Infectious Disease Unit, University of Ibadan, Dr. Oyewale Morakinyo. Good morning, sir. Welcome. Please join us on the table. And Professor Adeshola Olumide. Thank you very much, ma'am. Good morning. We also have with us very special guests that we've invited, the Deputy Vice Chancellor of the College of University of Ibadan, the Dean of the Faculty of Clinical Sciences, the Sub-Dean of the Faculty of Clinical Sciences, the Dean of the Faculty of Public Health, the Dean of the Faculty of Dentistry, the Dean of the Faculty of Basic Medical Sciences, the President of the Ibadan College of Medicine Alumni Association, ICOMA Worldwide, and the Secretary of the College of Medicine, University of Ibadan, and we'll welcome them to the first row in front as they arrive. And of course, we cannot forget you, distinguished ladies and gentlemen who have graced us with your presence today at the 52nd Annual Dokita Symposium. Welcome once again. Please give yourselves a round of applause. Before we get into the meat of the matter and address why we're really here, I would like to invite the Editor-in-Chief of the Dokita Editorial Board, Mr. Pelumi Adejimi, to come and give the welcome address.
Thank you very much, Angela. Good morning, everyone. Good morning, distinguished guests, respected speakers, esteemed colleagues, and all members of the audience. On behalf of the Dokita Editorial Board, it is a great honor that I welcome you all to the 52nd Annual Symposium and the 41st Journal launch. This year's theme, Contemporary Threats to Nigeria's Public Health, Infectious Disease, Flooding, and Research Funding Deficits, highlights the present challenges of our nation faces and the need for collaborative strategic action. For over 6 decades, the Dokita Editorial Board has been a torchbearer for academic excellence, fostering dialogue on critical issues. Today, as we converge to celebrate these significant threats to public health, we hope to ignite discussions that will lead to impactful solutions for our healthcare system. I extend my heartfelt gratitude to our keynote speakers, who would also be members of the panels, and all guests gracing this occasion. Let us make this symposium a platform for innovation, inspiration, and change. Thank you all, and I wish us an insightful and productive event. Thank you.
Thank you, sir. And now the board chairman, Professor Omigbodun, will be giving us an address.
The chair of today's occasion, Professor T.O. Alunge, the representative of the Vice Chancellor and the Provost, Professor Gule, our esteemed speakers. I think we are still expecting the third leg of the tripod. Distinguished guests, special recognition of somebody who wears two caps here. She is a long-time faculty advisor and also a representative of what I will call a Dokita cornerstone, and that is Dr. Joko Adeleye, who is representing herself and also representing Professor J. Adeleye. All the reviewers present, members of the Dokita Editorial Board, members of the proprietor or the proprietorship of the Dokita Editorial Board, and that's the University of Ibadan Medical Students Association. I was expecting that the president would be around, but doesn't seem to be here yet. Distinguished members of the press, ladies and gentlemen, today is another occasion for a Dokita outing. For those who may not know, Dokita has been existing continuously for the past 64 years. And it's been the flagship of medical student journalism in Nigeria, and journalism in the broadest sense of it, because Dokita, apart from focusing on science, also explores society. So it is in all ramifications. So I'm glad that that noble tradition has continued. And today we are having a sandwich of activities. We are having the symposium, which will deal with a very important topical issue. We are going to award the prizes to the winners of the Professor J. Adeleye essay competition, which had been concluded earlier in the year. And we'll be launching the latest edition of the journal. As you can see, it's a very, very rich menu. And we mustn't take too much time before we begin to dig into it. But I will want to extend special thanks to our chair of today. He's part of Dokita. He's been part of Dokita for nearly 50 years. So he's actually not a guest. And if anybody has been associated with Dokita the longest, I think he stands in that role, because he was editor-in-chief, I think, for 2 years. And he's been the deputy chair of the Dokita Editorial Board for more than 20 years. So you can see in aggregate, more than a quarter of a century he's been associated with Dokita. And so I'm not surprised that once again he has accepted this service. And so we welcome you, and we welcome every participant at this event, and we wish you a lovely time with us here today. Thank you for coming.
Thank you very much, sir. Thank you very much, sir. Okay. Um, I feel like Prof has helped me to do a very mini introduction of the next person who's going to come up and give us an address, the chairman of the Dokita Editorial Board. So we'll be taking the chairman's address, but before that, I just want to add to what Professor Omigweden has already said about Professor Alonge. Please follow along. It's a lot, it's interesting and very inspirational. Professor Temitokba Alonge was born in Igbaro Alonge family of Oka Akoko in Akoko Southwest local government area of Ondo State on the 16th of March, 1959. He eventually went on to study at the College of Medicine, University of Ibadan, where he obtained his Bachelor of Medicine and Bachelor of Surgery degree in June 1983 in the top 5% and won the coveted Blair Aitken Prize in General Surgery in the same year. In April of 1991, he became a Fellow of the Royal College of Surgeons of Edinburgh and the Fellowship of West African College of Surgeons in April 1994. His passion for the care of patients in his country has prompted him to return to Nigeria in 1995 on completing his postgraduate training in the orthopedics and trauma surgery in England. Upon arrival, he was appointed lecturer in orthopedics and trauma surgery by the College of Medicine of the University of Ibadan. In August 1995, an honorary consultant orthopedic and trauma surgeon to University College Hospital Ibadan in September 1995, and thereafter promoted to the rank of senior lecturer in orthopedics and trauma surgery in University of Ibadan in April 1999. He popularized the concept of plate and screw fixation of fractures using the AO techniques, compounded the ceftriaxone polymethyl methacrylate antibiotic bead for the treatment of chronic osteomyelitis, and went on to design the Alonge Wale intraoperative antibiotic bead makers, which made bead making easier. He has served in many academic offices, such as the Subdean Undergraduate of the Faculty of Clinical Sciences and Dentistry, College of Medicine, University of Ibadan from 1999 to 2000, and the Subdean Postgraduate Faculty of Clinical Sciences, College of Medicine, University of Ibadan from 2002 to 2004. He was appointed the pioneer head of the University College Hospital Department of Orthopedics and Trauma in 2003. And between 2005 and April 2005, he obtained the International Atomic Energy Agency Training Fellowship in Nuclear Medicine. He was promoted to the rank of Professor of Orthopedics and Trauma Surgery, University of Ibadan in October 2005. By this promotion, Professor Temitokbe Alonge became the first professor of orthopedics and trauma of the University of Ibadan, Nigeria. He has been involved in various collaborative studies far beyond the terrain of clinical sciences and inculcated translational research activities in addressing clinical problems. The highlight of some of his contributions to the scientific community includes and are not limited to the list that I will read now. He compounded the ceftriaxone polymethyl methacrylate antibiotic bead for the treatment of chronic osteomyelitis using the Belfast technique in Nigeria. He designed the intraoperative antibiotic bead maker as a point of the technique to enable surgeons prepare the desired quantity of antibiotic beads. He demonstrated the duration of elution of antibiotics from dry beads at tropical room temperature and in phosphate buffered saline. He demonstrated the relationship between the cartilage mantle of the periarticular osteophytes and the cartilage mantle of the normal articular cartilage using the scanning electron microscope, and thereby proposed the etiopathogenesis of periarticular osteophytes. Osteophytes have been tagged repair tissues, which have been wrongly cited, and his doctoral dissertation revealed that the rate of confluence of osteophytic chondrocytes in the monolayer culture far exceeded the growth of chondrocyte from normal articular cartilage. Professor Temitokbe Alonge is currently leading his research group in evaluating the expression of serum monocyte chemoattractant protein 1 in homozygous sickle cell anemia patients with acute bone pain. He created the concept of state emergency medical services at a 2-day workshop which was conducted at the British Council in 1996 and has since been adopted by many states of the Federation. As a professor of orthopedics and trauma surgery, he initiated the basic trauma care course in Ibadan for reducing the number of preventable trauma-related deaths. He is the Chief Executive Officer of the First Health Dynamic Synergy International Limited. Till date, he is widely traveled and has over 150 academic publications in peer-reviewed journals. His community services include membership of the Oyo State COVID-19 Task Force and chairman of the Oyo State COVID-19 Technical Task Force from 2020 till date. He's a devout Christian, he had a loving family man with an enviable passion for his profession, and he's also a golfer. He's an honorary member of the Dokita Editorial Board and the longest served chairman of the Dokita Editorial Board. Ladies and gentlemen, please, with a standing ovation, can we welcome the chairman of the Dokita Editorial Board, Professor Temitope Alonge, to give us his address.
Thank you very much. You may be seated. Please pardon my hoarse voice this morning. I think my sinuses are playing up because of the time of the year. Can I crave the indulgence of the editor-in-chief of Dokita to ask that the third speaker is on ground? Would you want to welcome her to come up and take her seat? Dr. Emi. Dr. Andekambi helped me out at COVID-19, so I'm very grateful. And also the representative of the Chief Medical Director, my boss in the hospital, Professor Shola Olawe, Professor of Ophthalmology. Thank you very much. Now that my bosses are seated, I think I can make my comment. First, I want to appreciate the chairman of the board of Dokita, Professor Omigbadun, my very senior and amiable colleague, former president of the West African College of Surgeons, and a thoroughbred researcher and an OBGY, professor of OBGY. Soft-spoken, gentleman, but a man of great honor and passion. Thank you very much, sir, for the privilege to work under you as Deputy Board Chair. I also want to acknowledge the presence of some of my colleagues. Professor Akintunde Udukogbe, his hair has been this bushy since we were in medical school. We graduated in 1983. It has not receded, and I don't know whether it is the amount of Lycor that he has had the privilege of drinking as a gynecologist. One of our colleagues made mention of that on the social media, on the WhatsApp group, that Professor Udukogbe's hair has not receded. So please welcome Professor Akintunde Udukogbe. And of course, Dr. Joko Adele has refused to come upstairs, but she's right there amongst us. Oftentimes, for programs like this, Professor Ogbole did mention, the representative of the Vice Chancellor did mention, that if you had included food and drink very plenty, people are going to turn up in large numbers. But Dokita has never been given to such shenanigans. We are very disciplined and very decent. We believe in the cause, and we do what we believe is the right thing to do. So I congratulate us, irrespective of the small audience that we have or attendance. Please let me begin by saying that Dokita became the first platform, or the platform that launched me into research work. I graduated in 1983, had my internship here, and I proceeded to the Rural Comprehensive Health Center at Ogbona in the old Bendel State, now Edo State. And because I'd been used to academic publications in Dokita, what I was doing was mainly observational write-ups. I was told that you had to ensure that your environment where you're working is not only safe, but you must pick things out very quickly. So it didn't take me time to observe that all the patients that had goiter that came to this comprehensive rural health center came from the same village. And my greatest suspicion was when I had a 4-year-old girl with goiter, and then I saw a 20-something-year-old man with goiter. So I went through the records and found out they came from the same village, which was high up in the hills. So I visited the village as an NYC doctor, and I went over to the local government to collect iodinated salt, on the premise that Professor Luri would say 20% of male patients with goiters will end up with malignancy. And I was worried for this young man, and I didn't want many more to come from that center. I couldn't publish that. It wasn't as exciting as the third case. The second case was a young girl that was brought by the mom with clubfoot. And I looked at the mother, she also had clubfoot. And then the grandmother came with them, she also had clubfoot. So I didn't need anybody to tell me that clubfoot can be an inherited disease. I didn't need, do you need anybody to tell you that it can be familial? Of course not. But the one that excited me that I published in Dokita, my very first publication was in Dokita in 1984. It was a case of a very young couple who thought they had infertility, in quote. And what was the complaint? Every time the woman had a normal menstrual flow, it was offensive in odor and it was darkish in color, and the husband was becoming impatient. So I took the normal swab, high vaginal swab, and did all this stuff, found out it was sensitive to ceftriaxone, but I then added gentamicin, which was going to augment the functionality of cephalosporin. So she had the injection for 5 days. The next month that she bled, it was fresh blood. And the next month after, she didn't come back to the clinic. This was just when I started my NYC. Well, I was rounding up 11 months after she brought her baby and named the baby Timitokpa in the native language. And so it was a case of straightforward endometritis. And that was, for me, they thought I was a magician. And so that was my first publication in Dokita, and that's the first publication that I still cite. From then on, it was a roller coaster effect. So I want to encourage you that don't just stop as being members of Dokita Editorial Board. I want you to take after our board chairman, who is a prolific writer and a great researcher. So you do exactly the same. Let it be outstanding. I know many people belong to various clubs in medical school, but let it be that it's on record that you're a member of Dokita Editorial Board, and it must show in your academic performances in the future. I want to believe that you're going to take that. When I was invited, or I was told I was going to chair this symposium, two things came to my mind. Did I commit an offense? I stumbled into public health, but I think as we get older in the profession, sir, you become a public health expert or public health professionals. But Professor Adeshola, they don't like us coming into their midst because they believe that we've enjoyed our world as OBGY, because Professor Migbadun also is a public health expert. They think we've enjoyed OBGY and we're coming to meet them where they're supposed to be enjoying their daily bread. They think people like us who are orthopedic surgeons have no business coming to public health, but I've discovered that as you get older in the medical profession, you are more of a public health expert or professional than your normal profession. Now, who cares whether Professor Odukogbe can operate about 5-6 cases into me? Who cares? Nobody cares. But if he comes and tells me, I have looked at the pattern of ovarian cancer in a particular area, I've traced it to their diet, I've traced it, that is when it's adding value. So you can't be tired. So please forgive me for venturing into your area. I had a lot of flack when they called me to come to Olodo, and but for God, if it was possible, they would have eliminated me from the midst of them, but I didn't die. Now, my being part of Olodo has now thrown me into a lot more of public health issues. So I'm not just interested in operating now. I want to find out what public health issues are responsible for these diseases that people do have. So please pardon us, but accept us into your midst. So when I saw the topic, I want to thank Dr. Adekombi. When we were designing Olodo, we insisted that Olodo must be an infectious disease center, not a makeshift shed. Today you must be very happy because Oyo State had an avalanche of diarrhea diseases in the last 3-4 months. Only those who did not get to Olodo died. Everyone that got to Olodo, over 60-70 of them, they were all managed successfully and they are alive and well. Because we told the governor then that pandemic is every 10 years, or it could be every 10 years or thereabout. But epidemic is a yearly affair. Therefore, let us have a place where we can manage epidemic. And this cholera came up as an epidemic. If they have meningitis, it will also be an epidemic. So Olodo has been reconfigured to take care of 3 major diseases. Anyone that is infective, pulmonary, they stay in the ICU. Those who have cholera and Lassa, they were staying in the HDU, which has a locked door. It has chlorine pits, just like we did here. And then they have the general one for either meningitis or cerebral malaria, and we have a special one for HIV/AIDS and hepatitis. So, but her counsel was what assisted us in arriving at an informed decision. So I want to believe that today you'll be well exposed. Don't jump into public health yet. Pick up your specialty. When you finish and you are old and tired, then you can go to public health and go and help them enjoy, the fruits of their labor. On account of this, I want to believe that today we're prepared to listen to these erudite scholars who I am confident will deliver on the mandate that has been given to them. Thank you very much, and I wish you the very best.
Please let's have another warm round of applause for the chairman of the occasion. Thank you very, very much, sir. Thank you so much, sir. All right, so we are about to begin, but before we do, I would like to sincerely apologize to the members of the high table that I failed to call up earlier, and I would like us to recognize them properly with a round of applause. Professor Olaoye, the DCMAC of the University College Hospital, is here, ably representing the CMD of the hospital. Thank you very much, Ma. Thank you, Ma. And we have our very esteemed speaker, Dr. Olukemi Adekombi, in our midst too. Thank you very much, Ma. Welcome. All right. So I'm very fired up now. I'm very interested. I've never really thought of public health as a domain that I will enter into, but I guess let me explore my interest, and then when I'm old and tired, I will eventually take a dip into the public health pool. But before we get started, before we listen to these lectures, I would like to invite Ms. Rhoda Fadairo to come and tell us about some of the activities and events that the Dokita Editorial Board has been up to since we were last here. Ms. Rhoda Fadairo.
Thank you very much. Right. Thank you very much. So I would like to appreciate the chairman of the board, the chairman of the occasion, our esteemed speakers, our guests of honors, and our consultants and teachers that are available today, and my fellow students who are here to grace the occasion. Thank you very much. So my name is Rhoda Fadairo, and today I will be talking about activities of the board. Thank you very much. So at first, I would be telling us about Dokita. So the Dokita Editorial Board is an organization comprising medical students of the University of Ibadan, and it was established in 1960 and is the foremost medical student journal in Nigeria and West Africa in a whole. It's responsible for the publication of Dokita, which is the journal of the University of Ibadan Medical Students Association. Dokita today has 41 editions to its reputation, and copies of our previous editions of the Dokita Journal are available at this event. That is the current one and previous one. And if you would like a copy of the previous one, you can just visit our board room at ABH G Block to get your copy. Now, activities of the board. We have 3 major activities we do in the board currently. And one of them is the annual symposium, which is a topical issue, which is where topical issues are discussed, like today. And we also have the Professor J.A. Adeleye National Intermedical School Essay Competition, where our board chairman has explained, and the winners of this year's competition will be awarded in the symposium. The third of our activity or our program is the Emeritus Professor O.O. Akinkugbe International Medical School Quiz Competition, and this is done biennially. And the objectives of the board. The objectives of the board as thus: 1, to coordinate opinion and information in the field of medicine, to foster academic and social interaction among medical students in Nigeria, to maintain contact and cooperation with other bodies of identical interest within Nigeria and abroad, and the last one, to promote the art of research and writing amongst medical students. Our mission: to create a platform where medical students are not only inspired but empowered to engage in research and boldly share their findings with the world, regardless of the scale of their projects. 2, this platform will be a catalyst for transforming curiosity into impactful discoveries, fostering a culture of innovations and collaborations among future medical leaders. It will celebrate every step of the research journey, amplifying voices and ideas that have the potential to share the future of healthcare. The next few slides will be showing our different journals which have been published over the years. So we have the Dokita Heart and Lungs, which is our volume 25, number 1, which was published in August 19, let's see. Which was published in August 1999. And the next one is the Trauma edition, which is the volume 32, and was published in April 2007. The next journal is the Dokita 50th Anniversary edition. This is a landmark edition or landmark journal. The next is the Hematology edition, the Public Health edition, the Tropical Disease edition, the Emeritus Professor O. Akinkugbe edition, and our General edition, which was in 2017. Now, this next slide is showing one of the articles in the Emeritus Professor O. Akinkugbe edition. So, as an achievement that we have now, which is being indexed in AJOL, so if you have any articles you'd like to publish and would want it to be, should have more visibility now, especially to the African Journal Online, Dokita is now on AJOL. And we would like to also officially call on articles now for our next edition. And this is a picture of our former and current editorial members. Thank you very much.
Thank you very much, Ms. Fadairo, for that very brief yet illuminating reports of Dokita Editorial Board's activities. Right, now we are down to the meat of the matter, why we are here today. So, Our first speaker is an infectious disease specialist that received her medical degree from the University of Ibadan, Nigeria. She is Dr. Olukemi Adekombi. Thank you. She's a Master of Public Health concentrating in global health from the Harvard School of Public Health, and she underwent her residency training in internal medicine at Abington Memorial Hospital, Abington, Pennsylvania, USA, and had her subspecialty specialization in infectious disease at the University of Maryland Medical Center, Baltimore, Maryland, USA. She is board certified by the American Board of Internal Medicine in Internal Medicine and Infectious Disease and is a fellow of the American College of Physicians. She's a senior lecturer here at the University of Ibadan and an infectious disease physician at the University College Hospital, Ibadan. At the University College Hospital, she is the foundation head of the Infectious Disease Department, clinical lead for infectious disease outbreak response, and oversees the infectious disease isolation centers. She is also currently serving as the acting director of the Infectious Disease Institute, University of Ibadan. Her research interests include antimicrobial resistance and stewardship, HIV/AIDS, tuberculosis, emerging infections, and neglected tropical diseases. Ladies and gentlemen, please help me welcome with a very warm round of applause Dr. Olukemi Adekombi as she gives a lecture on the sub-theme Infectious Disease, Burden, Impact, and Strategic Response in Nigeria. Thank you, ma'am.
They're working on my slides. I'd like to welcome Professor Shola Oguni. Such a pleasure to see you, sir. Thank you very much for coming. And while the Professor Alonge's citation was read, I have to let you know that it was actually abbreviated. He has two other titles that I want to tell you about, or two other things he does. He's also a geriatrician. Did you know that? He actually runs a program for the elderly in Ibadan, and his nickname is Oko Arugbo. My mother-in-law attends the program, and my mother-in-law's mother has been a beneficiary of his care, even in recent times. Thank you very much, sir. The other hat he wears is that I don't know if he still is, but back in the 1970s, he was a Sunday school teacher. So when my older brother and sister were really young and my parents were residents here at UCH, they used to attend, I don't know if it was Christ Chapel or somewhere else, but Professor Alonge, then a medical student, was one of their Sunday school teachers. Until now, he asked specifically after my brother. So he's a man of many parts, as you can see. I also would like to apologize for coming late. I was actually here about 15 minutes to time, and I was told that they were not quite ready to start. And so I asked the organizers to call me. I would be in my office, but they didn't call until when I came down. So I apologize. I didn't like to come and see my teachers seated, so apologies, please. And lastly, I'm just trying to kill time because my slides are not ready. If you take a look at all the women on the panel, what do you notice? We're all wearing green. We did not plan it. It was completely coincidental, but it shows you that we're in the spirit of Christmas. So this is the holiday season, and we all chose to wear green independently, and I think it's really nice. So I'll just begin as soon as the slides are ready. Okay, so I've been given about 30 minutes to talk about infectious diseases, the burden, impact, and strategic response in Nigeria. And what I'll do is I'll try to give a general overview, and then I'll speak about a few specific infectious diseases just to kind of buttress the point. Unfortunately, infectious diseases continue to dominate the landscape of morbidity and mortality in Nigeria. However, of recent, the non-communicable diseases have begun to rear their head, and they've actually taken over as a leading cause of mortality in recent years. In particular, this is specific for ischemic heart disease, so it's beginning to be a competitor. As we know, many infectious diseases are closely linked to poverty, and the current economic climate has pushed many Nigerians into that category. And even for many of us that might not consider ourselves poor, we've seen our purchasing power dwindle in recent times. Nigeria can be considered both a rich nation and a very poor nation. More than 40% of Nigerians live in abject poverty, according to the World Bank. And we also know that there's an immense amount of wealth in this country. Nigeria has the highest GDP in Africa, but a very low per capita income. Part of the severe economic burden, as we know, of infectious diseases or health in general is because of the out-of-pocket payment pockets that we have, out-of-pocket payments that we have to contend with. So when you think about the spectrum of infectious diseases in Nigeria, it's a very broad spectrum. And when I was asked to give this talk, I thought about it. What do I talk about? Should I talk about the classic three, HIV, TB, malaria? Should I talk about antimicrobial resistance? What do I talk about? But there's so much to say. So I'll just touch on them, and just to mention them as we go along, you have an idea of what I'm talking about when I say infectious diseases. So we have the big three: HIV, TB, and malaria. They are very well funded by international and local funders. They remain a big problem. A lot of money has been spent over time, but these diseases continue to ravage the population. We also have our vaccine-preventable diseases like chickenpox, measles, and so on. We also have enteric infections, which are actually a leading cause of morbidity and mortality in children under 5. And we also have the ubiquitous respiratory tract infections, which we are unfortunately not vaccinating for as well as we should. We also have those infectious diseases of epidemic potential, like Mpox. Remember, we no longer call it monkeypox. Mpox, Lassa, and cholera. You may or may not know this, but we're squarely in Lassa season. Of course, we can't talk about infectious diseases without speaking about the emerging and re-emerging infections. Many of them are linked to travel, climate change, conflict, and these are diseases like COVID-19, dengue, and other viral hemorrhagic fevers. And then we have antimicrobial resistance, which I'm particularly passionate about. And if any of the students here have gone through the infectious disease posting with me, you will know that it's very important to me, and I think it should be important to all of us. And it actually causes more deaths than the big three combined. And it's not something we think about. We don't really think about antimicrobial resistance. We think we can all prescribe antibiotics. We don't think about the consequences of what we're doing. But AMR is now with us, and it has come to stay. And we should also talk about neglected tropical diseases. Many of them are parasitic diseases like schistosomiasis, trachoma, filariasis. And these diseases they affect people who are the poorest in our communities. And they're not neglected because they're difficult to diagnose. They're also neglected because they affect the poorest people who have no voice. If these diseases were diseases of affluent males or females, they'll probably have better answers than they do. Other neglected tropical diseases are endemic fungal infections like histoplasmosis. So like I mentioned earlier, I'll talk about a few of these infectious diseases to buttress the point of the issue of infectious diseases in Nigeria. Anybody who knows me knows I cannot speak about infectious diseases without talking about HIV. So if we look at the numbers of HIV in Nigeria, about 1.8 million people are currently living with HIV in Nigeria. This data it's UNAIDS data, and it's a few years old, but it's not very far from what's currently obtains. We have about 107,000 new infections every single year. And this accounts for 38%, almost 40% of new infections in West and Central Africa. We tend to think that HIV is more of a big problem in Eastern and Southern Africa. It is true, but in West Africa, in that sub-region, Nigeria is really disproportionately affected. However, Nigeria is also kind of headed in the right direction. A lot of money has been spent, a lot of resources have been committed, and we have some results to show for it. This progress is, however, being threatened by challenges with funding, lack of universal health coverage, and donor fatigue, healthcare worker fatigue, complacency. Probably about 10, 20, maybe 20 years ago, on the radio we heard a lot of jingles about HIV and so on and so forth, but these days we're not talking about it as much, because many people think it's not a problem anymore. That's not the case. HIV remains a huge problem. Now, to the issue of what is the progress that is being made. This graph shows us within the years of 2010 and 2019, people living with HIV who know their HIV status. We said about 1.8 million people were infected, and in that period of 10 years, we saw the number of people who are aware of their status grow to about 1.3 million. So many people do know their status, but there's still a lot of work to do. Again, of those who are living with HIV, how many of them are on antiretroviral therapy? Remember that antiretroviral therapy is life-saving and it's free of charge to the patients. But it's still not everyone who is on these life-saving drugs. But we can see also that over time, more and more people are receiving these life-saving drugs. What about incidents? Are we still getting new cases? New cases are dropping, that's for sure. But we still have quite a bit of incidents. So these slides are just showing us progress. We're making progress. The interventions are working, but there is still work to do. Now this graph, while it shows some progress, it's also quite concerning. Why is it concerning? It's concerning because it shows us AIDS mortality per 100,000 population in Nigeria. And what does it show us? It shows us that between 2010 and 2015, AIDS mortality, you see this steady downward trend. And from 2015 onwards, it has kind of plateaued. So people continue to die at about the same rate. And in spite of everything that's been done, we're still losing our patients to HIV. Why is this? A lot of these patients who die of HIV are those who have advanced HIV at the time of diagnosis. And for many of these patients, when we place them on drugs, it's too late. Even though they're taking drugs, they just can't muster a response and they succumb to the disease. This graph shows us in green the percentage of people living with HIV whose initial CD4 count was less than 200. Less than 200 is it's one of the definitions of advanced HIV. So nobody should be getting diagnosed when their CD4 count is less than 200. We should be catching them early because we have life-saving therapies that will make sure that their life expectancy does not differ from the rest of the general population. So we need to do something about our patients with advanced HIV. So just to summarize the last few slides, we know that the numbers of new infections are declining, but Nigeria still has the highest number of pediatric infections globally. In fact, when you attend the HIV meetings, it's been said that if we can control pediatric HIV in Nigeria, we have controlled pediatric HIV globally. External funding is dwindling, and our governments are struggling to fill the shoes of the external funders. Back in the early days of the HIV response, there was so much money and so many resources committed to the fight. And the problem was, how do they even spend this money? How do we assign this to projects? How do we procure commodities? We have the funds, but we don't even know what to do with it. But now, the money is drying up. A lot of our money for HIV comes from PEPFAR, which is the President's Emergency Plan for AIDS Relief, which was instituted by George W. Bush. And the US now has a president that has promised to cut funding for all kinds of external international aid. So we can expect that whatever we have is going to dwindle. Global fund money is also dwindling. And the plan is that the government of Nigeria, as these funders pull back, the government of Nigeria is supposed to step in and fill those shoes. But that's not the case. As far back as 9-10 years ago, when I joined the faculty here, patients who were admitted to the hospital with HIV had free care, admitted in the hospital. So we still give them free drugs, they still get free consultations in the clinic, but if they were admitted, they would get CT scans, chest x-rays, blood work, medications from the pharmacy, bed fees, everything was written off. And then that stopped. So initially it was CT scans that stopped, then X-rays stopped, then blood tests stopped, then blood bank fees stopped, and then drugs, and then now they're paying even their bed fees. In those days, they even got fed for free. This was not many, many years ago. It was about 8, 9, 10 years ago. So we're running out of funds. Advanced HIV remains a problem because of late presentation and disengagement from care. So either people are coming in late, or they come in, they get treated, they get better, they disengage, and then they come back when they become very sick again. Then there's also this phenomenon of graying of the HIV population. Graying of the HIV population refers to the phenomenon where the general population of people who have HIV has aged. So HIV, we think about it as a disease of young, mobile, sexually active people, but these people are living longer because of life-saving medications. So where we used to target the 15 to 49 age group, we have patients that are in their 80s, we have patients in their late 70s, and that's not uncommon. And many of them are even new infections. They're actually getting infected in the last few years. So it's really something that is changing the landscape of HIV, and of course, non-communicable diseases are becoming an issue, where their diabetes is acting up, their hypertension is acting up, they're dealing with malignancies that are not necessarily HIV-related malignancies, but these are just issues that come with aging. They're dealing with dementia, cognitive impairment, and these are things that the traditional HIV programs were not equipped to deal with, but we now have to figure out how to include them. They were not equipped to deal with them, but we have less resources to now deal with them. So it's really a bit of a problem. And of course, stigma and discrimination are still very much alive, especially against key populations. So by key populations, we mean people like gay men or other men who have sex with men, sex workers, people who inject drugs, and transgender people. So a lot of discrimination and criminalization of these activities prevents people from identifying with any of these groups. And by doing that, they are not able to access care. Just a little bit more about key populations. So in the general population of Nigeria, prevalence is somewhere in the 1.4, 1.5% range. But for people who are sex workers, prevalence in that group is 16.7%. For those who are men who have sex with men, 25%. Transgender people, 28.8%. Very, very high. But what we don't realize is that these people that we call key populations also have other lives. So sex workers are not just sex workers. Many of them are women who are just trying to feed their children, who have lost their husbands and just have found no other way. Or they even have their husbands alive, but they can't take care of their children. So they double as sex workers and they take the disease home. Men who have sex with men, many of them are married men with families. So if we don't work on key populations, they still will affect the general population. So our stigma and discrimination is going to come back and bite us. So the bottom line is that Nigerians are still getting infected with HIV and dying of AIDS. Late presentation and diagnosis are an issue. Access to HIV care is limited by economic hardship. Some people cannot come to the clinic because they don't have money for transport. Some people are not even aware, because we're not talking about it as much. People have preconceived notions that if you have HIV, you can go to a herbalist and they'll cure you. You can go to the church and they'll cure you. And of course, stigma and discrimination. Now we can talk a little bit, let's switch gears a bit and talk about tuberculosis. Still a leading cause of morbidity and mortality. And according to the Global TB Report 2024 from the WHO, it showed that TB might be the leading single pathogen responsible for infectious disease deaths globally. I know I keep saying that many things are responsible for deaths. I said non-communicable diseases, and now I'm saying TB, but non-communicable diseases as a group. But as for a single pathogen, for one single pathogen, TB is looking like it might be the culprit. Remember, I also said AMR is responsible for a lot of death, but AMR is across many, many different pathogens, okay? So HIV and malnutrition continue to drive incidents in countries like Nigeria. HIV, while we're slowing down, we're not there yet, and we have a lot of malnutrition. If you talk to the pediatricians, they'll tell you that for the first time in maybe 25 years, they're beginning to see cases of kwashiorkor and marasmus again. I don't know if you've heard that. They're actually seeing that. When we were medical students in the late 90s, we saw a few cases. There were so few that whenever a case came in, we would tell everybody will come and look at the patient because you may not see another one while you're a medical student. So it was something that had been eradicated, but now they are seeing cases of kwashiorkor again. And so there's malnutrition, undernutrition across the spectrum of life in Nigeria now as a result of economic hardship. Drug-resistant TB is also highly prevalent in Nigeria. Diagnostics are inadequate, particularly in children, because they are unable to produce sputum. TB has been with us for so many years, and we've made so many giant strides, but we still fail to realize often that we still have a lot of difficulty diagnosing our patients. There's still many patients that test negative with multiple tests, and then they get better with treatments, and you would think that by now we should have perfected the diagnosis and treatment of TB, but we have not. Even the drugs are imperfect. Southeast Asia and the Western Pacific regions, however, they have higher cases than the WHO Africa region, but our population is smaller. They have higher numbers of cases. So our own population is smaller, so we have a higher burden of disease. So some of our TB data from Nigeria, there were 499 new cases last year. And among people living with HIV, 25,000. And if you think about the proportion within the population of HIV and the general population, you see that the incidence is much higher in people who are living with HIV. Drug-resistant TB or rifampicin-resistant TB incidence is also quite high, 9,400 patients. And TB deaths in HIV-negative people, 64,000. That is a lot of deaths. And TB deaths in people, that's HIV negative, and those with TB, 6,700. I can tell you that in our practice, maybe 8 out of 10 of patients with HIV who die during hospitalization or in the early entry into care, shortly after entry into care, they die from HIV, from TB co-infection. This is from the 2023 Global TB Report, and what it shows us is, I'm not sure how well it projects, but the WHO tried to draw colored rings or circles around different groups. So there are 3 global lists of high burden countries for TB. They're the ones that are high burden for just TB. 30 countries are on that list. There's another list that is high burden for TB that's associated with HIV. 30 countries are on that list. And there's another list that's high burden for TB that's either rifampicin resistant or multi-drug resistant. And Nigeria is on each one of those lists. So that's a huge problem. This shows us the reported number of cases by age. And if you look at the bands between 25 and 30, ages 25 and 34, and 35 and 44, that's where the bulk of the patients are. And these are the patients that are working, that are economically productive, that are raising their families, that are growing the economy. And so you know that anything that's affecting them will inadvertently affect our economic productivity. And we look at the funding. There's little funding, domestic funding compared to international funding for tuberculosis. It's our disease, it's our problem, and we really need to find local solutions and, of course, local funding. Again, this just shows us the estimated number of TB cases attributable to 5 major risk factors in 2023 in Nigeria. The major risk factors for tuberculosis are undernutrition and HIV. And as long as things are the way they are in our economy, undernutrition will continue to be a problem, and HIV as well. So, malaria. Malaria is our friend. We know malaria very well, right? I'm sure everybody here has had at least one episode of malaria. That is your citizenship stamp. If you have not had it, you are not Nigerian. So, Nigeria is responsible for 25% of malaria cases globally. So, 1 in 4 cases of malaria across the globe occurs in Nigeria, and 19% of malaria deaths. Again, it's so mind-boggling that still we have not figured out malaria. I must say that malaria has been eradicated from some parts of the world, but where it's still a huge problem, we haven't figured it out. We have the highest number of cases globally, and things like internally displaced person camps, flooding, climate change, poor urban planning, open drainages, threaten to reverse the gains of malaria prevention. We also have diagnostic resistance. What is diagnostic resistance? It's this phenomenon where the rapid diagnostic kit that's been developed to diagnose malaria in a very low technology way and in a low technology setting, the organism has deleted the gene that encodes for the protein that the RDT detects. So the patient has malaria, you do the RDT, and it doesn't pick it up. It's a negative test. Not because the person doesn't have malaria, but because the organism is clever enough to know that carrying that gene is harmful to them. So there's diagnostic resistance, and of course there's fake drugs. We keep hearing about fake drugs. We heard about the amoxicillin recall, didn't we? So drugs continue to be an issue. And then the vaccines for malaria. Are we not very happy that there are now vaccines available for Nigeria for malaria? And there are, I believe, 2 states have already set their dates to start vaccinating their under 5 children. But why was Nigeria not included in those clinical trials? Why were we coming so late to the party? Why was it Ghana and Kenya? I will never understand. But I think many of us also know why people avoid Nigeria when it comes to clinical trials and sometimes high quality research. So Nigeria and similar countries, we fall into this cycle of illness and poverty. So you are ill, you lose your ability to go to work. Either you're ill or your loved one is ill. So you're taking care of your loved one. You lose income. You lose your financial and human capital, which of course leaves you vulnerable to illness. So if you don't have income, you may not eat as well. You may be more likely to develop some illnesses. You may not be able to pay for, insecticides to spray your home, and you may get another case of malaria. So it's like this never-ending vicious cycle. And the diagram on the right just shows us how these things perpetuate through this vicious cycle. Now, to antimicrobial resistance. It's the next big pandemic, and it has already begun. COVID-19 was very scary. I remember it vividly, but we don't realize that antimicrobial resistance is with us. Antimicrobial resistance refers to that phenomenon where an organism that would previously have been susceptible to a particular antibiotic is no longer susceptible to that antibiotic because of mutations and so on and so forth. And AMR causes more deaths than the big 3 combined. It's largely driven by inappropriate use of antibiotics and poor water, sanitation, and hygiene practices. Some of the WHO priority pathogens that cause severe disease and death include E. coli, Klebsiella species, methicillin-resistant Staph aureus, and carbapenem-resistant Enterobacterales, Pseudomonas, and Acinetobacter. These are the pathogens that we see from time to time in the hospital, and they really are killing our patients. And with antimicrobial resistance, we also include under that umbrella drug-resistant TB. So this is just some of the what was in the press about antimicrobial resistance. So this is a graph that shows the deaths attributable to AMR every year by the year 2050. 2050 is only 26 short years away, because I remember 2000 like it was yesterday. Africa, there will be 4.1 million deaths on average every year by the year 2050. When you look at a continent like North America, 317,000 deaths. That's a much smaller number. And they also have the ability and the money and the access and the resources to fight these infections. We don't have those things, and we are going to deal with a much larger number. If you look at Asia, you might say, oh, they're dealing with 4.7 million deaths. But their population is also much, much larger than the population of Africa. So the burden is on Africa. And within Africa, Western Africa is the hot point. And if anything is happening in West Africa, guess where it's happening? It's happening in Nigeria. So we need to kind of be aware about this. Pandemic preparedness. So I'm going to use COVID-19 to kind of talk about the things that we learned about our public health systems when it comes to pandemic response. So what COVID-19 did was that it exposed the inabilities of our existing public health systems to protect us from new pathogens. But at the same time, it showed us what was possible, that it was possible to leverage existing surveillance and laboratory networks to ramp up testing and diagnostic capacity to really sophisticated levels. Pre-COVID, hardly anybody was sequencing anything. Nobody was really sequencing. But now, you can probably sequence you can definitely sequence in every state of this country. And in many states, there are multiple facilities that have the ability to do genomic sequencing. We also know that misinformation and disinformation, they were almost as harmful as the virus itself. And it's something that we need to also put in place in pandemic preparedness. And like Professor Alonge was saying, We need to be ready for the next pandemic before it gets to us. So when we think about the economic impact of infectious diseases, what's the economic impact? We have the individual healthcare costs. More than 70% of healthcare costs in Nigeria is out-of-pocket spending. And many families, if you consider the fact that 40% of Nigerians are living below poverty, many Nigerians are just one illness away from catastrophic healthcare spending, where people are admitted on the ward, and by the time they are discharged, they've sold off all their property to stay alive. They've borrowed money that they could not even secure with any property. They've lost everything, and sometimes they don't even survive. These healthcare costs refers to money spent by individuals on medications, prevention commodities like insecticide-treated nets, vaccines, transportation to and from healthcare facilities, and so on. Then there's also the cost borne by the public sector or the government, and this includes commodities like medicines, diagnostics, vector control, healthcare infrastructure, research, and education. These are all government investments in the health of its people. And there's also lost wages due to the illness of the patient and the caregiver, and I've talked about this already. And there's foregone income due to premature death. So somebody comes to the hospital, it's a young man, and he has a family, and the man, unfortunately, doesn't survive that illness. Maybe it's an infectious disease, he doesn't survive the illness. He's never going to be able to make the money he would have needed to take care of his family. And these are the kinds of things, the impacts. Those children may never go to school. Their ability to maximize their potential may never actualize because of that infectious disease. And many of these infectious diseases, they affect the lowest socioeconomic stratum, and they hinder the ability of these individuals to contribute to the long-term economic growth of the country. And so instead of those people being part of the solution for the growth and economic development of our country, they're actually part of the problem. And again, our healthcare spending by governments is historically very low, much lower than what's recommended by the World Health Organization. So what are the obstacles to an effective response? The following need to be addressed: are complex political structure, weak governance, poor accountability, inefficiency, and corruption, lack of a robust population health and mortality data, insufficient financing for health and healthcare, suboptimal deployment of available health funding to purchase health services, and large population inequities. It's a mouthful. There's so many reasons why it's difficult for us to maximize our potential as a country, especially in healthcare. But there's so many examples of how even the money that's available to be spent is not necessarily spent on what it's meant to be spent for. It's spent on salaries. Salaries are very important because without salaries, healthcare workers may not be able to work and so on and so forth. But many of these roles of healthcare workers, they may not even be doing anything. We know people who don't go to work at all, but they get paid. We know we are struggling with an electricity crisis. We know how much IBEDC is expecting us to pay every month. It's all over the news. Is that really the best use of our resources? The little we have is not even, we're not able to direct it in the right in the right way to yield us the most benefit. And we really, a case really has to be made to our leaders, our political leaders. We need to make a business case for investing in health. We cannot continue to do things the way we do and expect that things will get better. So for us to have a good strategic response to infectious diseases, there needs to be access to quality health care services, decentralization of services, which to a large extent we do have. We have the primary, secondary, and tertiary levels of healthcare, but they're not really functioning the way they're meant to function. Because when you see somebody in accident and emergency for nausea, vomiting, and diarrhea, and they've come all the way from somewhere that's 40 minutes away or an hour away, and how long have you been having vomiting and diarrhea for? A day and a half. But was there no primary healthcare center in your area? Was there no secondary healthcare center? So we're overburdening the tertiary centers with diseases that can be treated at the periphery. So we're not really utilizing the different levels of healthcare and the proper referral system. There should also be universal health coverage. It's needed to cover the most vulnerable populations and the least able to cover out-of-pocket expenses, and who also happen to be the ones who bear the highest burdens of disease. We need to focus on under 5 mortality because it greatly skews our life life expectancy downwards. So our neonatal mortality, our infant mortality is so high, it makes our life expectancy 54 years. But if you remove that, you see that our life expectancy is actually not as bad as it looks. But of course, you can't remove it. So we need to deal with our neonatal and infant mortality numbers. We need to invest in prevention for our young population. Our population is very young. I think it's about 40% of the population that's less than the age of 15 years. We need to make sure they are vaccinated. We need to make sure that they have access to potable water. And we need to make sure that we're able to help them to live healthy rather than focusing on taking care of them when they get sick. There needs to be outbreak preparedness because whether we like it or not, we have these outbreaks from time to time. We have Lassa, cholera, Mpox, meningitis, and in the news over the weekend, it was sounding like we might have another wave of COVID-19. So they keep coming. So we need to be ready so that we don't destabilize the entire system once a new outbreak comes. There also needs to be community engagement. The community that these interventions are made for need to be part of the solution. They need to buy in so that when the solutions are taken to them, they accept them, they utilize them, and then can benefit from them. It's important that there's local manufacturing for essential medicines, vaccines, and other commodities. We also need to invest in diagnostic capacities. We need to improve our data surveillance and data systems. We need to mitigate the activities that lead to climate change using policy and legislation. And if you don't know, Nigeria is one of the 10 most vulnerable countries to climate change. We also need to leverage the private sector. About 40% or more, in fact, more than that, of our healthcare is sought and obtained in the private sector. So we need to regulate and involve the private sector in delivering key components of a strategic national health plan for infectious diseases. So for specific diseases, for HIV, we need to ensure that the handing over of the national HIV program to the government of Nigeria is done in a way that ensures sustainability of the programs. We need to be at the forefront of new therapies and advocate for access. So there are these drugs for HIV that are now available. They are long-acting injectables. They're a new class. For some of those drugs, you only need to inject the patient twice a year, and they're fine. Those drugs are not only more effective in driving down the viral load, but they improve adherence. If somebody has to take an injection only 2 times a year, as opposed to taking this medication every single day, it's obvious that they will do better with the twice-yearly drug. And the twice-yearly drug has quite a bit of error, if you're room for margin for error. If you're supposed to take your drug in June and you come 3, 4, even 5 weeks later, you're still okay. So it really helps adherence. And we also need to create an enabling environment for HIV research. And this is for all the infectious disease research, because it's mind-boggling to me that with all the malaria we had, there was no malaria clinical trial conducted in Nigeria. I still cannot understand. We are ultimately the biggest market for that vaccine, but I guess we just made it impossible for them to do those trials here. For malaria can be eliminated. It's been eliminated in other parts of the world, and we need to focus on man, parasite, and vector. It's not just about the mosquito. It's not just about the parasites and treating the patients, but we need to focus on everything. There was a study that showed that 23 to 37% of asymptomatic people in a population in Benue screened positive for malaria, compared with 0.5% of the mosquitoes. So when we think malaria control, we think mosquitoes. But the mosquitoes don't have malaria. We have malaria, right? So we're the ones that are infecting the mosquitoes, kind of, right? So most of the biomass of the parasite is found in us. So we need to figure out what to do about patients that are asymptomatic. In fact, they're not patients. There are people who are asymptomatic. They're carrying 99% of the burden, and the mosquitoes are just assisting them to spread it around, okay? So we need to focus on that as well. So if we need to eradicate malaria, the blood meal pool must be parasite-free, or at least as close to parasite-free as possible. Attaining a zero malaria status in Nigeria is possible. Of course, vaccines. We have to talk about vaccines. Vaccines are a game changer in malaria eradication. It provides required immunity for those vulnerable to malaria, ensures that many people don't get infected so that we don't continue to perpetuate this load of just malaria parasites in asymptomatic patients that actually serves as the true reservoir. And it reduces the number of hospital admissions for those who get infected. And it should be integrated as soon as possible into the national or extended program on immunization across all states in the country. When it comes to antimicrobial resistance, the National AMR Action Plan must be implemented and supported at the highest levels of government and decision making. There should be legislation to back this up and consequences for breaking the law. There should be tight regulation of drug quality, and diagnostic stewardship should go hand in hand with antimicrobial stewardship. You can't expect people to choose the right drugs if they don't have culture data and things like that to guide their choices. The government must increase healthcare spending, but budgetary allocations must be data-driven. We can't just say we're going to spend more on malaria because it sounds good. We need to say we're spending more on malaria because it's causing more morbidity and mortality. We need to know what states are most affected. We need to know what people are most affected and what age groups and so on and so forth. So we need data. We need to reduce reliance on international funders. It's a huge national security issue. If we can't keep our people safe unless help comes from outside, then from time to time we're going to get stuck. We're also going to be at the mercy of external forces. Universal health coverage must provide access to care for those who are least able to pay out of pocket expenses. And spending must also support social determinants of health, such as education, housing, insecurity, empowerment of women and girls, and harmful traditional practices. Thank you for listening.
Thank you very much, Ma. Please can we give her another round of applause? All right, so please ensure that you are taking down the questions, the comments that you have. Dr. Adekombi will be part of the panel session where you'll be able to ask any questions that you might have. So please, for all the speakers, just take notes that you can jot down your questions and then we'll address them during the panel session. So before we take the next sub-theme, I'd like to, on behalf of the Dokita Editorial Board, recognize some dignitaries in our midst. We have in our midst this morning Professor Oguni, a professor of medicine and a consultant neurologist. He was a past editorial consultant for the Dokita Editorial Board. We have in our midst Professor Ojukogbe, professor of obstetrics and gynecology and the current head of department. We also have in our midst Dr. Adebayo, the head of Department of Community Medicine. Please welcome him with a round of applause. We have Dr. Ajuwon, the medical librarian of the Latunde Odeku Medical Library. We have with us this morning Dr. Adeoshun, consultant ENT specialist, and a past editorial consultant of the Dokita Editorial Board. We have with us Dr. Adeleye, a consultant endocrinologist and sponsor of the Professor J.A. Adeleye Biennial Essay Competition, and Mr. Dairo, who is the Deputy Registrar and representing the Secretary to the College of Medicine. Welcome, sir. We also have in our midst student leaders, the President of the University of Ibadan Medical Students Association, and the President of AGA. All right. So, are we ready for the next session? Can I have a response? Are we ready for the next session? All right. Let's not get tired yet. So, our next speaker, Dr. Oyewale Mayowa Morakinyo, is an environmental epidemiologist and a senior lecturer in the Department of Environmental Health Sciences here at the University of Ibadan. He's a fellow of the Consortium for Advanced Research Training in Africa and a recipient of numerous awards and scholarships. He was recently inducted as a fellow of Nigeria Young Academy, a platform for fostering collaboration among outstanding researchers in Nigeria. Dr. Morakinyo has a multidisciplinary background spanning microbiology, public health, and environmental health. His expertise includes air pollution epidemiology, children's health, housing and respiratory infections, and demographic and health survey analysis. Dr. Morakinyo teaches undergraduate and postgraduate courses in the environmental health and has published extensively in both local and international peer-reviewed journals. He currently serves as the Deputy Chair of the Africa chapter of the International Society of Environmental Epidemiology and is the National President of the Environmental Health Sciences Association of Nigeria. Please, with a very warm round of applause, join me to welcome Dr. Oyewale Morakinyo as he speaks on the sub-theme, Environmental Disasters and Public Health, Flooding and its Ripple Effects. Good morning, sir.
Good afternoon, everyone. Good afternoon, my distinguished elders, teachers here present, colleagues, and students. It gives me so great pleasure to be standing you this afternoon to give this presentation and to have been invited as one of the speakers for this 52nd annual symposium for Dokita Editorial Board. Thank you so much to the organizers for having me. It was with so much mixed feelings when I got the invitation, because looking at the program and I saw the list of the calibers of people that will be, it was somehow, but I think I should be able to do justice to this presentation. So I've been asked to speak on environmental disasters and public health, flooding and its ripple effect. Permit me to also say that on the high table, I'm a Carter Fellow, and also the other on the high table we also have two other Carter Fellows who are my seniors, Professor Olumide and Professor Olawoye. Thank you for coming. And also to say that the focal person for the Carter program in UI is Professor Omigbodun. Thank you so much for the training that you've given to us, and we are very proud of you, sir, for all the things that you've been doing for us. And so to start with, I want to say something about environmental health. Environmental health is a sub-discipline of public health, and is all about assessing and controlling and preventing factors in the environment which can cause deleterious effects on our health. And so if you look at the environment, we have various aspects of the environment, and there's so many other things within the environment which we call risk factors that can cause problems within the environment and can also affect our health. So when you have issues like air pollution, when you have inadequate sanitation, when you have a radiation, issue of housing and health, and so many of all these things, when they result into disasters, they usually affect our health and oftentimes leads to death and also increased morbidity and mortality. So when you hear of disasters can occur anywhere in the world. So let's start with that. It's not something that is restricted to Nigeria. It's not something that is just common to sub-Saharan Africa, but it cuts across everywhere. Global is a global event. So disasters are events that occur when significant numbers of people are exposed to extreme events. When we talk of extreme events, these are man-made or natural events. When they go out of proportions and they lead to death, then you say that they're extreme events. So to which they are vulnerable, resulting in injury and loss of life, and often combined with damage to property and also livelihood. And oftentimes, apart from loss of life, we also see that there's also property damage and also to infrastructures that support human existence and human living. So disaster, like I mentioned, can occur everywhere. So it's not just limited to urban areas where we have the densely population. We also have, even in rural settings where we are sparsely populated areas, disaster can also occur in all of these places. So environmental disasters, these are events by natural or anthropogenic factors, that is man-made factors, that result in significant environmental, economic, and health impact. So as we go along with this lecture, you'll be able to see some of the effects that environmental disasters poses. So for this particular lecture this morning, our focus will be on flooding and like I mentioned, environmental disaster causes us so many things. We have issues related to earthquake, we have air pollution, drought, floods, wildfires, building collapse is also something that is common in Nigeria. And so we have all of these environmental disasters. So like I mentioned, our focus will be on flooding. And flooding is the rising of overflowing of a body of water, especially onto to dry lands. And it usually results in devastating natural disasters with significant implications for public health. So it affects our health, affects the health of the animals and also the environment. And so it's a perennial problem. It's something that occurs on a yearly across various countries of the world. And so there are different types of flooding. I don't want to bother with that, but just to mention that we have a flash flood that is caused when you have fast-moving waters from heavy rains, when it rains, and you have this fast-moving waters on our streets. We have a river flood. That's when the rain falls and the river banks they are overflown, and you have floods everywhere. You also have coastal flooding, usually associated with low-lying areas where you have strong winds and waves, driving this water onto nearby environment. You also have urban flooding, usually caused when drainages are blocked and failures to our drainage system. And this is something that is also usually very, very common in our environment. We find instances when it's raining, people tend not to. There's also this behavioral attitude, things that we do. People are of the opinion that they are not supposed to pay for their waste. And so when rain falls, you see people bringing their waste, pouring into drainages with the assumption that the rain will wash this waste, will take it away and help them dispose it. But you find out that at the end of the day, this waste block drainages and usually leads to flooding. So we have global statistics just to show that flooding is something that occurs globally across the world, and the impact is much. We have about 1.8 billion people, usually been affected, between 1925 since 1995 up to now, and it cuts across the continents of the world. We have in Asia and in everywhere. So flood is everywhere. In Maiduguri, in Nigeria, in September 2024 this year, in Florida, in India, and in Tanzania, floods cuts across the various parts of the world. So this is just to show us a graphical representation of the number of deaths that are due to flooding worldwide between 1998 and 2003. So it's something that's very, very unfortunate and leads to death. So for the 2024 floods that occurred in Nigeria, just this year, we find out that most states were also affected. We have Borno was the most affected and faced severe flooding. About 441,000 people and 309,267 persons were displaced. Occurred in Kogi, in Dandamawa, in Yobe. You can see all the number of persons who were affected. Also in states like, states like Bauchi, Bayelsa, Enugu, Jigawa, Kano, Niger, in Sokoto, in Zamfara, and other states, they were also affected. We can see this picture from Maiduguri, and this year 24, and houses were submerged. People walking through flooded waters, as a result of flooding. And it was as a result of a collapse of a dam, that resulted in the flooding and that occurred in Borno State. So we have all these pictures just to say people moving away from, people moving away from their houses just to survive, because their houses and where they live have been submerged with water. So we have pictures like these. People, these are pictures from Borno State, in Borno, showing people moving away from their houses. So what are the causes of flooding? Initially from heavy rainfall, from dam failure, the melting of the glaciers, that is, due to climate change, temperature rises and leads to the melting of the icebergs, and so we have water rises, and this also leads to in flooding. especially in most of the developed countries. We also have blocked drainages that result into flooding. So what are the causes of flooding? Some of them could say that they are natural from heavy rainfall. When we have overflow of major rivers, for example, the River Niger and River Benue, this is something that occurs on a yearly basis. When we have a coastal storm surges from human-induced causes, for example, deforestation, most of the vegetation cover that's supposed to protect our soils, have been cut away, and so the soils are they are left open and they are exposed. We have poor urban planning and drainage systems. Places where river paths, places where water is supposed to pass, people have converted those places to residential areas, and so water doesn't usually have places to pass through. And in such cases, we also have flooding. We have climate change-induced sea level rise, and when there are dam failure or release of water, and also pot pipes, and also poor agricultural practices from irrigation can lead to flooding. Also, inadequate spatial planning, when you have poor solid waste management, just like I mentioned earlier, particularly the exploitation of drainage system as dump sites are other causes of flood in Nigeria. And so this picture will also speak to that. We have most of our drainages, blocked as a result of people disposing waste into drainages. So what are the public health importance of flooding? We have the immediate causes like loss of lives, we have drowning, and also injuries from collapsed building, and so many other facilities. The displacement of millions of people from their homes, people have to leave their homes and move to IDP camps. We have destruction of crops and also livestock. Farms are washed away, crops are submerged, and people lose their investments. We have short-term effects like a waterborne diseases, usually related to cholera outbreaks. For that in Nigeria, we still have a sizable number of persons who practice open defecation, and so when rain falls, these fecal materials are washed from where they're deposited into rivers, and some people still depend on this river for their source of drinking water. We also have long-term effects like mental issues and also malnutrition because food insecurity because farm have been submerged. So we also have these pictures just to show people leaving their homes as a result of flooding. What are the public health impacts of flooding? And we say that human and animal waste frequently contaminate water and pathogens that can spread via feces. And we have several crops in Bayelsa State for the year 2022 flooding that occurred. There were instances where the graves collapsed and corpses were washed, away. In Niger State, about 500 corpses were washed away from their graves in cemetery in Niger State. So we have instances like this where you just see bodies being washed away and they are seen floating on waters. What are the environmental and economic ripple effects in Nigeria? One is there's soil erosion, there's contamination of rivers and water. We have economic impacts because damage to infrastructure, including homes and our roads, loss of farmlands and crops, worsening food insecurity, and also increased health costs due to disease outbreak. Still talking about the economics of flooding water, there are instances, especially to the north, where the roads are cut off because from collapse bridges, and so petroleum transportation to the north are cut off, and so people do not have ability to transport their goods and their food products to the south, and so that can also trigger inflation of prices, and when that occurs, can also lead to food insecurity. What are the health implications? There are several health implications that have been mentioned in the past with regards to occurrence of flooding. For the 2022 flooding that occurred in about 31 states in Nigeria, there were instances of cholera epidemic and a disease that resulted in about 460 deaths during flooding period. In 2023, the NCDC reported that about 2,052 cases of suspected cholera with a case fatality ratio of 2.7 occurred in 24 states in the first 12 to 26 weeks of year 2023. Also, river states, cross river states, and some other states accounted for the 25% and 57% of those cases. So what are the ripple effects on ecosystems? So flooding is not just about having effect on an health system, not just on the environment, but also even on our health system. So such effects include damage to facilities. During flooding, there are instances where health facilities were submerged, and so the practice of providing care and other services could not continue in such instances, where overwhelmed medical resources as a result of number of casualties that resulted from the flooding episodes. We also have displacement of population. A lot of people are crowded in IDP camps, and they can easily contact communicable diseases due to poor sanitation and also hygiene. We also have instances because people move to IDP camps and they don't have access to adequate potable water supply, and also adequate water to cater for their health. People suffer from waterborne diseases and also water-wash diseases. There are paucity of personal hygiene equipment, and so there are instances where people have to share equipment among themselves, and that can also lead to infectious diseases happening, transmission of infectious diseases, communicable diseases among individuals. Also, sexual assaults are also things that have also been reported in IDP camps. We have instances of rapes and also unprotected sex, and that can also lead to a increase in sexually transmitted infections. So also in the IDP camps, women privacies are compromised, and so safety is also compromised and dignity is also compromised, and so this can also increase to sexual harassment and sexual assaults. Also, because we have insufficient sanitary products as a result of the number of persons that we have in those places, and also the government not providing so much of these products, there will be deterioration in personal hygiene, and the women tends to, because there are no sufficient places to ease themselves, people also tends to urinate for, delay their urge for urination, and that can also lead to urinary tract infections. Also, emotional and physiological stress, people feel that their homes are gone, people are no longer with their families, all of this can also affect their health. So we have instances like this where the ID camps are overpopulated and we have overcrowding, movement is restricted, difficult to sleep, and so many other conditions are prominent in those IDP camps. So who are the vulnerable populations to flooding? We have the children and the elderly, we have pregnant women, low-income and marginalized communities, especially people in rural areas. And why are they vulnerable? Is because they have limited resources and healthcare. The geographical locations, so there are some places that are prone to have higher, they are more prone to having flooding, and also preparedness levels are things that make us to be vulnerable. Why does Nigeria currently stand? What are we doing? And is that most of our agencies that are responsible for flooding to tackle the issues, oftentimes what we do is after the event has occurred, that's when we wake up. For example, NEMA, they are more active in the aftermath of the disaster when something has occurred, not about preparing, not about taking proactive steps to ensure that this does not occur, or even if it's going to occur, it's going to have minimal impact on public health. So the lack of proactive outlook makes these agencies prone to being overwhelmed and unable to cater for large-scale impact of disasters. So we still have that global efforts outside Nigeria, people prioritize preparedness because they know that flooding is something that happens virtually on a yearly basis, and so they plan ahead. But however, in Nigeria, most of us, once the flood came and then we've been able to serve people, they go back to their houses, and that's the end of it. Nothing will be done until another flooding episode came on board. In 2022, we discovered that most states, about 9 states, not most states, we have some states that they did not even budget at all for flooding in their budgets, and that shows the level of how our government prioritizes this issue of flooding. In June 2023, the Nigeria Hydrological Service condemned the state government for their lack of interest in stakeholder disaster preparedness meetings. So they don't attend meetings, and they have no interest in putting in place measures that will forestall the occurrence of flooding in the future. So Nigeria is also significantly underdammed So I think it's now of recent that the federal government is saying that they want to commission and do some, provide additional dams. So we need to provide some additional dams so that this can serve as reservoir, and then when waters are released, they will not get to where people live. So what are the call to action? What are we supposed to do is to adopt contemporary technologies that employ geospatial infrastructure. We can learn from other countries or other climes who have done something with regards to flooding. And there's need for early warning systems. Oftentimes we have NIMET providing the information that flooding is going to occur, but nothing is being done. We don't help. Just you hear on the radio and also on social media that people should vacate such places. Where do you want them to go? Nothing is being done to assist in this set of people. So the government must work together to also enforce compliance with early disaster warning. And also we need to develop a culture for flood preparedness, prevention, mitigation, and response and recovery are things that we need to put in place. I will skip this and also go to conclusion for want of time. So flooding represents a significant environmental disaster with profound implications for public health. It has far-reaching ripple effects, like I've mentioned in the course of this presentation, on health, on an environment, and also on the economy. And a coordinated approach involving the governments, our communities, international stakeholders will go a long way in reducing the effects of flooding. Then we need to build resilient systems and address root causes to mitigate future impacts. And so there's a call for action for all of us. We need to commit to sustainable solutions so as to protect our health and also our economy. Thank you for listening.
Thank you very much, sir, for that enlightening talk. Please, can we give him another round of applause? I hope we're taking down our questions and marking our comments. The panel session is set to begin once we conclude with all the sub-theme talks. And so we'll be taking our last speaker for today, Professor Adeshola Olumide, who is a professor and a consultant community physician at the Institute of Child Health, University of Ibadan, and University College Hospital. She's also the director of the College of Medicine Research and Innovation Management Unit, that is CRIM. Professor Adeshola's research interests are in adolescent and young people's medicine and health, and she has served as the PI and co-PI on several national and multi-center studies covering communicable and non-communicable conditions and risk behaviors amongst adolescents and young people. She has a keen interest in using mobile technologies in adolescent research and interventions and in the use of participatory action methods, including photo voice, community mapping, and data walk in research. She was a commissioner on the WHO UNICEF Lancet Commission, A Future for the World's Children, and is a commissioner on the current second Lancet Commission on Adolescent Health. Professor Adeshola is the International Association for Adolescent Health Vice President and the Sub-Saharan Africa and the President-elect of the Society for Adolescent and Young People's Health in Nigeria. She is a member of the National Technical Working Group for Adolescent and Young People's Health in Nigeria, where she chairs the Technical Quality Delivery Subcommittee. She is passionate about building the next generation of researchers in adolescent health. And today, she is here to speak to us on the sub-theme, Research Funding Deficits, the Role of Local and International Investments in Advancing Nigeria's Health. Please, can we give her a warm round of applause as she comes up to give her talk? Good afternoon.
Good afternoon, sirs and ma'ams, my teachers, on either side of the divide, on the high table and on the higher table as well. Thank you very much. It's a pleasure to be here. Dr. Adekomi was talking about between 2000 and now, having gone so fast. I would say between when I was on that side, listening to others doing the presentations, and now that I'm on this side, it's as if I just blinked. And so be prepared that in a few years' time, you are the guys that are going to be giving the lectures, and we are going to be listening to you. Thank you very much, Professor Alongesa, for emphasizing the importance of community medicine and public health. I remember sitting in the lectures and listening to Professor Asuzu those days saying that nobody cares if you have a problem with your little toe or your little finger, and I didn't understand what he was talking about. That nobody also cares if you keep saying that you are treating people in the hospital. The more important thing is that you stop so many people from coming to the hospital so you don't overwhelm your health facilities. And so I'm happy that as we mature and move on in our specific disciplines, we all get called upon to do public health work because it's critical. It's important that we work in the hospitals, but more than that, we need to address the issues that we have in our environment and in our society. I don't know if Professor Alonga remembers, but I started out wanting to be a pediatric surgeon. At the point when I changed my mind and said I was going to do public health, my senior colleagues said they were going to report me to him. And I said I'd made up my mind that I think with my personality, I'd get bored with just doing inspection, palpation, percussion, or auscultation. Inspection, palpation, percussion, or auscultation. I mean, I felt there was a lot more to life than sitting in a clinic. And I think I have had a good deal. And we are all welcome to come and join us in public health. It's a big space. And everybody is needed. ONG is needed, surgery is needed, ENT is needed. ENT, good afternoon, sir. Thank you very much for teaching us very well. One of our colleagues just produced, I think it was an application that can help with sign language. He's an ENT surgeon and he worked with other people in computer science. And so the world is a big space for everybody. Professor Olawoye has come into the public health space. She's left the clinic alone. You are welcome. Dr. Adekombi is already there with us. I mean, everybody is here. Professor Migwado is in the forefront of public health. And like Dr. Morakinyo said, he's the one that is in charge of CARTA, that's the Consortium for Advanced Research and Training in Africa. And through his work in public health, at least 3 of us here have gotten to do our PhDs. And so that's very useful. So please, public health is for everybody. Whether you start out in core public health, or in surgery, or in ONG, or in ophthalmology, or in infectious diseases, or anywhere else. All right, so very quickly, I'll talk about research funding deficits, the role of local and international investments in advancing research in Nigeria. I hope I can move on. All right, thank you very much. And maybe also to say a big thank you. Now, as I've seen College Research and Innovation Management units, a big thank you to Professor Guniyi, sir. Thank you very much for the foundation you laid in the research office. And now the College of Medicine is in the forefront when it comes to research management, because if you don't have a viable research office, there's not much you can do with research these days. All right, so very quickly, I'll move on. So I can't figure out. Oops, and I've taken it out. All right, so I'll be taking us through this outline. I'll give a brief introduction. I'll talk about research funding, then talk about research funding deficits and prioritization, talk about some of the local and international investments that we have now. I'll give my recommendations, and then I'll conclude very quickly. I'm told I have 30 minutes and no longer 40 minutes, so I'll try and make this as quick as possible. So to introduce, I'd like to unpack some of the keywords that we have in the topic, and these are research, funding, deficit, and investment. And I think this is important so that we have a mutual understanding of the issues I'll be talking about. So talking about research, what is research? By definition, it's been described as the creation of new knowledge and or the use of existing knowledge in a new and creative way so as to generate new concepts, new methods, new understandings. This could include synthesis and analysis of previous research to the extent that it leads to new and creative outcomes. A mouthful. But basically the thing is, we see a problem. We are able to quantify the problem. And using various methods, we define what is causing the problem, what might be promoting the problem, how do we solve the problem, and then we come out with our conclusion. So every day, we are asking questions. Why is it that Nigeria is not spending enough funds on research? Why is it that we don't have enough funds being spent by our government on malaria control, on TB control? Or why did we get to the party late? Dr. Adekombi, I hope you have an answer to why we got to the party late when it came to the issue of malaria vaccines. Then funding deficit. What is a funding deficit? Not a clear definition, but this also talks about the fact that once you have a deficit, it's because you have more outgoes than income, basically. You have a lot more that you want to do than the amount of funds that are available. Dr. Adekombe alluded to the fact that the economy is getting slightly tighter, and even the richest and the so-called comfortable among us have had to adjust their budgets. It's because there is a funding deficit, and it just means also that when it comes to research, we have inadequate support for research activities. What then is an investment? So it's a process of exchanging income during one period of time for an asset that is expected to produce earnings in future periods. So the gains of investment are in the future. And that's the reason why many people get tired about putting their funds into health and into health research, because the gains are not necessarily immediate. We might be reaping the benefits of these gains 10 years down the line, 20 years down the line, 30 years down the line. However, if we do not invest anything, there is nothing for us to reap at the end of the day. And so this is a clarion call that any money that is spent on research is money that is spent wisely. So looking at the research funding landscape, I have the research cycle there. I'm sure all of us have been involved in research in some way or the other, even the medical students also. As an undergraduate, you are expected to do some form of research as part of your program. And so what then do we do during research? Now, this is important because I'm going to be talking about the various points at which investments are required for research. So you have to conceptualize. I have an idea. Then you write a proposal. Then you look for funding. That's the big key. Many people stop at the source for funding because that can be tricky. Then you implement, then you write it up, and then you utilize the findings. Different ways of utilizing the findings. Most of us publish a paper. Many of us will write a dissertation or a project. Some of us will go to the media and share our findings. And some of us will sell our products and get a patent and make money off it. I think those are the fewer number of people that do that with their research compared with those who just publish a paper. All right, so why then do we conduct research? Is it important at all? Why is it important? And I say here that it's important for general good to solve problems. Somebody thought that it is not ideal for an audience to come for a meeting and stand for a 1-hour meeting, and somebody developed chairs, and we can now sit on chairs. Somebody felt, for me to go in a boat from Nigeria to London, it's going to take so much time. Why can't we fly like birds? And so now we have aeroplanes. And so basically, research is for a general good. Even though a byproduct is the individual benefit of career advancement and self-gratification. But sometimes we flip this and we look at the individual benefits and we prioritize this over the general good. And once we don't have those immediate benefits, it's easy to give up. But I'd like us to go away with this today with the knowledge that research is for a general good. It's to solve problems. And so we should expand our horizons and expand the questions that we ask when it comes to research. What then are the sources of research funding? Various sources here. External to the institution, that's extramural or intramural. We have government funding, we have non-government funding. And like Dr. Adekombe said, most research funding in Nigeria these days comes from outside of the country. It is not our Nigerian government, it's the US government, the Canadian government, the Australian government, or other governments that are plunking their funds into Nigeria. So I'll go through some of the funders we have. For government funders, international funders, we have NIH, very popular. NIHR, we have some embassies that also give us funds. We have UKRI, and then we have the various UN agencies as well that also give funds for research. Then we have industry, corporate organizations, foundations, philanthropies. And so if you are thinking of research, know that there is money out there. The pot of money may be shrinking, or maybe it is the same. And you have a lot more players coming for the money, but there is funding for research, and there's fund that we can also access as students and as lecturers as well too. Then we have various NGOs also that give funds for research, and we have some individuals too who give us funds for research. Now, federal government of Nigeria gives funding as well too. And many times when we think about research funding, we think about money, naira and kobo, dollars, whatever, alone, but then you also have other things that come as funding for research. And so infrastructure is a very big aspect of research funding. Funding for fellowship training, for those of us who did West Africa College of Physicians or National College of Physicians exams, Government funded us to be able to do our fellowship training. Government paid for our exams. Those are all parts of the funding that government gives into research. And also you have things like travel grants to go and present your work at conferences. Examples of other government ministries, departments, agencies, and parastatals like give funds are the National Primary Healthcare Development Agency. Then you have sometimes technical support from Nigeria Academy of Science. NIMAR also gives research grants as well. And so you have those different sources. UN agencies, professional associations give money for research. I'm trying to go quickly so I can finish on time. Then industry also includes companies that operate for profit. And so the thing to note is that for industry, even philanthropy for industry is also to make profit. I mean, the thinking behind a company is I must make profit. And so it's important that we understand that so that we can work together with them and so that they can fund research. So examples of companies that contribute to research include Shell Petroleum Development Company. We all know Cadbury, pharmaceutical companies, commercial banks. We have 54G as well. They also give funds. Then you have foundations and associations. And so, for instance, your grandfather bequeaths you a lot of money. Rather than spend it on building a house, you put it into a foundation and then use that for research. So we have in Nigeria things like the Kanoanko Foundation, Kola Daisy Foundation, the Dorcas Cancer Foundation, the T.Y. Danjuma Foundation, and we also have institution alumni associations. I mean, we should give it up to our University of College of Medicine alumni. They do fund research as well too, and that has been very helpful. Thank you very much, Professor Dokita. It's your set, and we are grateful for the funds that you give to our researchers. Then we have individuals as well. So we have endowments from individuals, grants, gifts, and we have the various examples on the screen. So who then are the largest donors when it comes to research? The 10 largest, the top 10, according to this publication, and this is a 2012-2013 publication. However, a 2016 publication, sorry, that used 2012-2013 data, but things haven't really changed so much. Most of the funders are in the developed countries, global north, like we like to call them. So the US top seed by NIH, European Commission, UK Medical Research Council, Institut National de la Santé, I think, that's French. Wellcome Trust. So these are the top 10 globally. And what that paper showed was that the US was the top funder. The largest philanthropic funder was the Wellcome Trust. And so you have lots of funds under Wellcome Trust for different categories. All 10 funders came from Northern America, like I said, Europe or Oceania, so developed countries. The largest Asian funding organization was the Natural Science Foundation of China. China has made it into the big leagues. And the thing is, I mean, I think the China story should be an encouragement for Nigeria. They started like a developing country, and now they are in the League of Nations, and everybody must listen to China. For Latin America, we had an organization from Argentina, and in Africa, the largest funder was the South African Medical Research Council. Looking at national research funding mechanisms in West Africa, this was a commission study. And what they found out was that there was a lot of low investment by African governments on research and development. On the average, African governments spend less than 5% of their GDP on research. South Africa, Kenya, Egypt, and Morocco had the highest spend. And also, like Dr. Adekombi said, there is an over-reliance on foreign funding. A lot of what we do in research depends on funding from foreign organizations. Now, this is a database of funding agencies put together by some of our colleagues, looking at the research funding landscape in Nigeria. If you look through this as well, a lot of the organizations you still see in this Nigerian document are still the foreign organizations. Yes, we also have some Nigerian organizations like TEDFund, NIMAR, Nigeria Artificial Intelligence Research Scheme. The publication is available online, and I'd like to urge us, those of us who like to do research, it's been done in different categories: health, agri, science and technology. You can go there and see who are the top funders so that we can start to target them when we are writing our proposals. So in College of Medicine, looking at information from our college research office, top 5 funders are still international organizations: the NIH, Bill and Melinda Gates Foundation, the National Institutes for Health and Care Research, Pfizer Global Medical, and World Health Organization are top 5 funders for last year. Oops, I think I've skipped too fast. All right then, so even though our topic is looking at research deficits, I chose to call this section Research Funding Deficits and Prioritization, because many times it's not just a deficit, it's a prioritization. Like Dr. Adekombi said, 20 years ago, HIV was key. Everybody was putting funds in HIV, but things have shifted. A lot of funds are now going into climate change. And so priorities change, and when priorities change, the funding also moves with those priorities. Sometimes also the funding can determine the priorities. So I have funds and I decide I want to do sexual and reproductive health. Now that would affect the landscape also of research funding that is available. Now talking about prioritization, I have a good story. So this is from China. So whereas most of the information out there is that funding for research has reduced, for China, they have increased their funding. They increased funding for science and technology, and that shows that the government is thinking ahead. It's thinking that in a few years' time, if we put these funds in now, there are benefits that are going to accrue to us down the line. If we shrink the process of research, we are going to get less recognition. Thank you very much, sir. All right, so now this is an article from the Conversation Africa, also showing that in the US, federal funding for major science agencies is at a 25-year low. And so the US pot of funds has shrunken. And you can ask yourself a question. If suddenly your 1 million naira salary cannot take you home, who will you prioritize? Your family or your neighbor? You prioritize your family. And so if the US pot of funding has shrunk, they're going to prioritize US research. I think we will just come along as tag-alongs, and because they know that if they don't do some things for us, everybody will be in trouble, which is probably why malaria is still with us. If malaria was a US illness by now, they would have found a vaccine for it long ago. HIV came after malaria. HIV had got a vaccine before malaria because HIV affected them. It didn't affected us as well, but it was their own problem. And so countries are going to continue to prioritize what are their own problems when they are dishing out their pot of funds. Now, so this is in Britain as well. Slashing research funding is a blow to global Britain. And so Britain has also shrunken their pot of funds, which means it's going to affect us as well too. And this is from the WHO, looking at investments in research and development for neglected tropical diseases. The green line graph is funding from the public sector. That has dipped. The next one is the orange one, funding from pharmaceuticals. There was a dip in 2018. It went down again 2019, and then has started to climb slowly. But it's still way lower than the funding from the public sector institutions. The pink line is private sector philanthropic funds. That is also low. That's also kind of going down. And so we see that most of the funding really is from public sector funds, but even that one is going down. And so it's a clarion call to us that we need to do something to address funding for research. Looking at funding, the funding landscape on health, migration, and displacement. Dr. Marakinyo talked about the impact of flooding on displacement. You have people moving to IDP camps. The pot of funds has also gone down. Whereas the numbers of people who are being displaced, the numbers of people who are migrating, the numbers of people who require these funds is on the increase. Now, looking at Sweden as well, shock. I mean, this University World News says shock as government axes funding for SDGs-related research. And so even Sweden itself has shrunken its pot of funds. And what we do know is that when there is a reduction in global funds, it has a ripple effect. It goes beyond the country that reduces the funds. It goes beyond their own region. And so when Sweden shrunk their funds, some of our researchers said this. This was in a publication that's available online as well. Now, someone said, for a researcher working on food security at University of Nairobi, the Swedish Research Council's decision in 2023 to slash $16.4 million in grants for development research was more than a personal blow. A Ghanaian biochemist and executive director said that Swedish costs affected at least 20 of the academy's research scientists. Since they all teach students, however, the ripple effect is about 5 times that number. And so the scientists were affected, their students that they were teaching also were affected. But Africa has thought about a way forward. And so we have what is the Agenda 2063, which is a vision for us to have the Africa of our dreams. And so the African Union, the member states of African Union came together and said, what do we want Africa to look like in the year 2063? And what are the things we need to do to move ourselves from a continent that has all the bad indices to a continent that can take its place among the League of Nations? And with respect to research, they decided to raise their national gross expenditure on research and development to at least 1% of their GDP. 1% of GDP sounds like a small amount. What does that mean for Nigeria? For 2023, our reported GDP was 362.8 billion US dollars, not Naira. Now, 1% of our GDP is about 3.6 billion US dollars. Imagine if 3.6 billion US dollars is available to fund research right from the cradle, because research doesn't start. I mean, if we leave our research endeavors to when we have people who are employed as lecturers, we have left it till too late. All the things we do should start really from the cradle, from preconception. And I'll give us some examples as we move on. And so we hope that our government will get to the point of spending 1% of our GDP on research. This year, so TED Fund is one of the major funders of research in Nigeria. And the Teacher Education Trust Fund came about as a result of many struggles of ASU, that's the Academic Staff Union of Universities. And through that, we have a 2% tax taken from industry to put together in a pot the National Research Funds, and part of it is given for infrastructure development and in government tertiary institutions, and also for research. So this year, over 683 billion naira was approved to beneficiary institutions of TED Fund. 683 billion sounds like a lot of money. And then about 5 billion was approved for funding for 188 successful research proposals. And so periodically, TED Fund issues a call for research funding, research proposals, and our scientists apply. And so for 2023, they received about more than 4,000 concept notes, out of which 185% were successful. That's a 4.3% success rate. And the government now gave out about 5 billion naira, which came to 3 million US dollars. That is really not a lot of money. However, at least we are making progress. This is much more than what was given out in 2023. So we are making baby steps, taking baby steps. Now, looking at the role of local and international investment in advancing research in Nigeria, I have this quote, that while external support has been crucial for research in Africa, the urgent need to strengthen local and government funding to ensure sustainability cannot be overemphasized. Dr. Adekombi mentioned the fact that by the time PEPFAR funds started to dry out, what happened? First CT scans went, x-rays went, drugs went. I think food must have gone first of all, before all those other ones. Food went, and everything went. And so if our government is not positioned to take up the funding that donor funds have provided at the initial stages of those of the research or the project, what happens is that there's going to be a shutdown. And we have seen that severally with a lot of donor-funded projects. Many of those projects come with a big bank of money, but a donor cannot feed you forever. You should think about it. Is it possible that you leave your own children and keep feeding your neighbor's children perpetually? At a point, you expect your neighbor's children to stand up and do something. And so while you might have some benevolence towards your neighbor's children and see them through primary school, secondary school, university, I don't know how many of us want to continue to fund our neighbor's children through university. They want to do a master's, you fund them. They want to do a PhD, you fund them. You ask yourself, when is this child going to grow up and start funding others? And so it's important that we start to look inwards. In Nigeria, how can we get funding for research? Because research is essential for development. It's essential for economic growth. It's essential for us to be who we need to be. The thing, like I said, is it's an investment. And many times, we don't get to see the benefits of those investments until much later. So looking at local and international investments in research, it's multifaceted. I had said that before. We have multiple players. And investors should understand that investing yields dividends to everyone. It's going to yield dividends to the pharmaceutical companies. It's going to yield dividends to the nation. It's going to yield dividends to every single person. And so it's important that we focus on research. All right, so going back to the research cycle, I have a box that says pre-conceptualization. And like I said, it's important that we start thinking of research right from the cradle. So what then is the role of local and international investments in research at the pre-conceptualization stage? This is before we start thinking about research. Now, it's important that we have international government and private sector investment in preconceptional care. And so you ask yourself, what does preconceptional care have to do with research? If you don't take care of the women, if you don't take care of the men, who are going to end up becoming the parents, such that they are healthy and they value education. You're going to have a lot of parents who are having children who have absolutely no value for education, talk less of research. And so it's important that at a very early stage, we put systems in place to ensure that we have a healthy population that can move on into the productive workforce. Pregnancy and childbirth are also critical. We must take care of our pregnant women. We must take care of our children. We must immunize our children. There must be quality healthcare available to all through the ages. We also require appropriate policies and school environments. If you compare children growing up in a government primary school with those growing up in a private primary school, the odds are already stacked high against those in the public primary schools. They are still using chalkboards. The entire environment actually is averse to learning. Whereas if you put your child in a private school, from the time they are in kindergarten, they are being taught to be curious, to ask questions, to explore. Nobody shuts them down. But you put your child in a school where those things are not there, the early childhood stimulation is gone. Whatever you're not starting to do at secondary school level and university level is coming too late. If you speak with a lot of lecturers in UI, they will tell you that when they see master students, they want to send many of them back to go and take undergraduate courses. And that shows that there has been a problem at the undergraduate level. If you speak with secondary school teachers in government universities, government secondary schools, they will tell you that they are doing the work of primary school teachers. And so if the foundation from primary school is not laid, forget about having anybody who thinks about research. Nobody's going to think that it's important. Nobody's even going to think in a critical way. And so that will also affect the types of research that we can do. And so adequately funded education is important, from primary to tertiary to master's to doctoral level to postdoctoral level. A couple of weeks ago, there was this debate about PhDs in Nigeria, and people were basically questioning the quality of PhDs in Nigeria and saying that people can get them for money, they can get them for, in all manner of ways. If we don't devote money, if we don't invest in PhD, in doctoral level education, it's difficult to get people to do research. If we don't make research look very lucrative, if we don't make it look exciting, if we don't make it appear as if we are indeed solving problems, nobody is going to be interested, and everybody's just going to leave us and leave us to our Nigeria. And other things that could happen is we have our Nigeria and they all move to other countries to develop their countries for them. Now, at the point of conceptualizing design, what is the role of local and international investment in research? They're important for idea generation. And so things like having fairs, idea generation fairs, hackathons, those are important places where young people, where older people, whether you are an established researcher or an early career researcher, you can attend these events and get ideas about things that you can do. It's also important that our local and international investments put money into mentorship opportunities. Dr. Marakion talked about the Consortium for Advanced Research and Training in Nigeria. Fantastic program. The bulk of their money, or all of their money, correct me if I'm wrong, sir, is international funds. But what CATA does is to invest in PhD doctoral training for researchers within the African continent, keeping them in the continent as well so they can continue to change the landscape of research in their different countries. And so those also have mentorship opportunities. We also have exchange programs, industry internships, then funds for attending conferences and scientific meetings. I think we also do need to take a look at our medical curriculum. Yes, our curriculum has been tweaked, but we need to start to expose our medical students to research early on. Research not just within the university, but even research in industry. Can they go to various industries and see what are the problems that they have that they can solve? If our research questions are in line with what industry wants, they are more likely to fund us than if our questions are just at the basic level. It's also important for us to have investment in attending conferences and scientific meetings. We do have a number of organizations that are in the industrial sector who fund this. So you have a lot of pharmaceutical companies that fund researchers and fund PhDs, they fund master students to go for conferences. Then infrastructure development, very important. We do have, so while we have government funding for infrastructure, we also have, and we also should have, private sector funding for infrastructure. There's 54Gene. They have fantastic laboratories, and they do a lot of research as well, too. We need a lot more of those ones. So it's not just everything on the neck of government alone, because this neck of government is getting more and more fragile by the day. Then we need adequately equipped classrooms, libraries, laboratories, internet, affordable housing. The good thing is we have an example here where we are sitting. This is a government auditorium, but it was renovated from private sector funds, alumni. And so we need to see how we can start to tap into those other pots of money if we intend that research must take the place that it needs to take in our country. So what else can local and international investments do when it comes to proposal writing and funding? Also, on looking at manpower development, it's important for them to provide opportunities for mentorship. Grants writing workshops, internships, these are all places where people learn. They learn hands-on. And so it's not just sitting in class and taking a lecture, but you actually learn hands-on to write proposals and to access funding. Then when it comes to funding research, we require seed grants for all career levels. NIH has different career levels. I know the College of Medicine has given out seed grants before to early career researchers. We also, like I mentioned, we have our alumni who also give grants to early career researchers. When it comes to implementing research and writing up, we need mentorship opportunities, sponsored writing retreats, manuscript writing workshops, and policy writing workshops. We need to, like I said, take our research also from our desks to the policy environment, from our desks to the users of research. It's not just supposed to be for us alone. When the users of research see what we are doing and see how what we have developed has improved their lives, they are more likely to bring their funds in. But when they don't even have an idea of what we are doing, they just feel, oh, University of Ibadan, big place. They go there and they read and propound theories. They don't understand what our research does for us. And so we need to start thinking about what do we require in our environment. Dr. Morakinyo talked about flooding. There is no reason why we shouldn't have solved the issue about flooding in Nigeria. I don't think there's anybody anywhere who does not know that in Nigeria we have dry season, we have rainy season, we have harmattan. So year in, year out, rainy season comes. So why do we wait until there's a major flood before we start racking our brains and looking for NCDC, looking for foreign aid to sort our issues out? If, as an institution, we are located in a host community where flooding is an issue, and we have not solved it, we really should bury our heads in the sand. Because one of the reasons why we have institutions like that is to solve local problems. If we cannot solve the local problems, how are we ever going to solve the international problems? And so it's important that we start talking to our researchers. Our research must add value. It must add value to the person on the street. It must add value to the person in school. That way, we can see, we will see more private sector funding in research. So I've started talking about this, utilizing findings, also mentorship opportunities, article processing charges. And so, I mean, there really is a lot that appears to be stacked against the researcher in Nigeria. If you ask us, so the institution expects that we publish in high-impact journals. To publish one paper in a high-impact journal, the nicest of them will get $500 from me because they're from Nigeria. And then everybody's rushing there, and you're waiting to get your paper published. Many of them charge as much as 2,000, 3,000 pounds. If nobody is going to pay those fees for you, you will look for any journal and dunk it there. And I'm happy, like we were told earlier on today, that Dokita is in Agile. That is part of our own investment in research, because it shows that we have a place for medical students, we have a place for doctors, we have a place for anybody who does research to publish their findings. So hands up to you on that. So other ways in which local and international investments can contribute to research: hosting researcher industry events. In College of Medicine, we have our iResearch events where we bring industry to discuss and to dialogue with researchers so that we can mutually solve problems. We also need to facilitate patenting of research outputs. We must think about, I mean, at the point where we are developing our research questions, we need to think, what is the final product going to be? And how am I going to get this final product from my bench, from my laboratory, from my community, to make it a commercial product? When we start thinking like that, I think it's going to be much easier for industry to come along and say they want to work with us. Because like I said, industry is set up to make profits. And also for sustainability, we do need sustainability. When the funding from outside ends, what happens? It's going to be our own local investments that is going to drive sustainability of our product. Also, translation of research findings to products. It takes money to go from the bench to a product you see on town. That is a lot of money. And so it's important that the private sector contributes money to patenting, contributes money to moving products from the bench, from the laboratory, from our field onto the shelf. There's scaling up of interventions. We have so many interventions in Nigeria, so many. They are pilots, small projects. You have a small project in Ibadan, a small project in Ilorin, a small project in Kano, a small project in Zamfara, and we have proven that these interventions work. So the next step then is to scale up. And who are we looking up to scale up? Many times we are still waiting for these same donor funds, and it's not supposed to be like that. Our government should be able to come in. The private sector should be able to come in to see that we scale up these interventions, and by so doing, we improve life for everybody on the street. Now, looking at local versus international investment. So, it's important that we have international investments. The thing is, we do not want to be over-reliant on them. So what are then some advantages? If we want to compare local investments, international investments, what are the pluses and the minuses? So for local investments, these are essential for funding the foundation of research, funding for our schools, primary schools, funding for our healthcare, funding in secondary schools, funding in university level. Our local investments are going to do a lot more of this compared with the international investors. It also promotes prioritization of local needs. And so, if for instance you had going back to the example of your own household. So in your own household, your children like rice. If you are going to give a gift to your neighbor's children, you're probably going to give them rice. Why would you want to, if they like, let me think of something exotic. If your neighbor's children like cheese, why would you go and buy cheese for your neighbor's children when you are buying rice for your own kids? And so your own priorities are going to most likely determine how you are going to, the funding you are going to give to other countries. And so when our funding comes only from external sources, they are going to foist their own priorities on us. And there's nothing we can do. We all have to just fall in line if we want any money at all. And so promoting our own local investment ensures that our research priorities are put on the top of the list. It also ensures that our research priorities are both locally and internationally relevant. And then it promotes sustainability, it promotes uptake of research findings, and it's necessary for us to attain our goals of being the Nigeria and the Africa that we want. Now, looking at international investments, why are they important? For a common global good. I had said earlier on that we do research for good, for the good of everybody. When the Wright brothers were thinking about creating airplanes, I'm sure they may not have remembered where Africa was. But today, their efforts have paid off, and everybody all over the world is riding a plane. And so they will still probably continue to give funds, that is the international funders, just because of a common good. And if COVID has taught anybody anything, nobody is isolated. So if a problem starts in China, it is going to move around the whole world in a twinkle of an eye. And so for that reason, it's more like necessity is laid upon the foreign donors to continue to give out, no matter how small, something to us. It also promotes exchange of ideas. No one is an island. No one can stay in a vacuum. And so we do need the exchange of ideas from the global north and the global south. Then while we're also waiting to transition to our goal of 1% GDP, 1% of our GDP to be spent on research, the funds that we get from donor agencies and from international donors will still be helpful to ensure that research does not just stop in Nigeria. And then whether we like it or not, developed economies are ahead. And so for the benefit of the common good, they would like to assist us to also develop and come along with us. And then it could support research, training, and retention of researchers within the continent. And so for instance, funding like the Carter funding has promoted retention of researchers within Nigeria. A few of the Carter fellows have left the country actually, but at least many more are within their countries. So what then happens if you don't have enough investment in research? Number one, we will lose our skilled manpower, and it's happening before our very eyes. I think one of the fastest ways to relocate to the global north is to apply for a master's or for a PhD, and you are gone, you and your entire family. And so if we don't invest in research, if we don't invest in our country, if our own local industry, our local people that have funds do not invest in research in Nigeria, we're going to lose our skilled manpower. At the end of the day, we'll have inadequate numbers of manpower who are trained, or they will receive inadequate training. I mean, I think every month, almost every month, probably every other month this year, one of our fathers in medicine has retired. And I keep telling myself, oh, if we ask all the medical students in the room, how many of you are planning on staying in Nigeria? Maybe one hand will be up. And by the time that one hand goes up and he looks around and sees, I'm the only one, that hand is going down. And so if we continue to produce, if we continue to mass produce for a foreign economy, then when our fathers in the profession retire, we are going to be begging them to come back because somebody has got to teach the next generation of medical students. And so it's important that we invest in research and development. Then also, international research and development agenda will remain prioritized if we do not invest adequately in our own research. Our national economic growth and development will remain suboptimal. Research is intrinsically tied to development, to health, to everything. Because we cannot continue to do things same old, same old, same old. You can imagine if all of us were still riding the bicycles our grandfathers rode. Nobody will be here today. You can imagine if we are still relying on the technologies of 20, 30 years ago. We wouldn't be here. We would be totally irrelevant, completely forgotten by the outside world. And so we don't want that to happen. So we do need to invest in research. All right, so what then are some recommendations I have? One quote from Otiwateng: Africa's over-reliance on foreign funding that could be suspended at any time highlights the need for diversification of funding sources and for African governments and the private sector to step up. We cannot continue to rely on dole-outs. We will not get to where we are going to as a country and as a continent. And then countries generally attain the 1% target of global research and development investment as a percentage of GDP when business finance research and development surpasses publicly funded research and development. That long quote simply means the countries that have done it, the countries that have attained 1% of their GDP, it's because the private sector has come in to fund research. And so if there's a take-home message, one of the many take-home messages is that we must begin to woo the private sector. Let them see the importance and the need for them to put their funds into research if we ever hope to attain 1% target of our GDP in research. So what are the things that governments can do? First is to invest in education, like I said, at all levels. And we have the West and Central Africa commitment that looks at ensuring that there is education, we have health, and that our young people are brought up and that they are healthy, and such that when they become adults, they can become responsible and viable adults. And so our governments have signed to this commitment. And it's important that as we have signed to this commitment, our governments must put their money where their signatures are. We also need to prioritize research funding. I can't say that enough times. I have shown us what it means if Nigeria commits 1% of her GDP to research and development. We need to promote industry investments in research. There are many things we can do to achieve this. I mean, industry is not going to come and dash you their money if there is nothing for them to benefit. We can give tax rebates to industry, for instance. We can ensure that if there is a product, the industry at least owns the patent or partly owns the patent for a slightly longer period of time, simply because they have invested in research. We can encourage industry to set up laboratories and then work in partnership with them, public-private partnerships, so that we do not have to depend only on our research laboratories in our own institutions. We can also use those from the private sector. Then we must ensure our research agenda is in tune with current realities. We have done the same types of research over and over and over and over and over. When I was a medical student, a lot of the research that was done in public health was knowledge, attitude, and practice. There's nothing wrong in it. It's a baseline. But we must move from knowledge, attitude, and practice to what do we do with the knowledge? How do we influence the practice? On the clinical side, a lot of the research has been a description of hypertensive patients in our clinic. We know that by now, before you read that paper, you know the results. So this percent of male, this percent of women, this percent, so we must move also from those kinds of basic, though important research and start looking at groundbreaking things. So women keep on coming. If you ask for what are the common causes, for instance, of postpartum hemorrhage, you will still say the same thing. Sorry, postpartum mortality. It's hemorrhage, what else? Infection, sepsis. So what is it that, why is it that these same causes appear to be perpetually bound to Nigeria? What can we do to break those things and to ensure that our mothers are surviving better? Because the hemorrhage, the sepsis, the eclampsia should no longer be killing mothers in Nigeria. It's old. Now, looking at the private sector, I'm almost done. The private sector, it's important to understand that funding research is a worthy investment. And so we should tell all our uncles, our aunties, our chiefs in our communities who have all the big companies that they should invest money in research. Governments also should incentivize industries that contribute to research. The private sector needs to partner with higher institutions to discover and develop talent. I know Microsoft does that a lot. They go to UI, University of Ibadan, hold all these fairs for students in computer science. That should extend not just to Microsoft, but to other companies as well. We must also set up innovation hubs to promote research for development. Sorry, I've gone backwards. So what then should we do as research institutions? We need to have a research agenda that is in line with government and with current realities. We also have to invest in research infrastructure, including research management. Research management is very key to research. We must prioritize research that answers relevant questions and that has impact. We need to emphasize contemporary research training at all levels. Secondary school level, there is some research that can be done at secondary school level. There is some that should be done at first degree level. There is some that should be done at postgraduate level as well. Then we need to promote industry research collaborations and think tank meetings. We must embrace generating funds for research from multiple sources. Gone were the days when universities could think that we are the ivory towers, everybody will come to us. Gone was the day when UI would think, I'm the first and the best, all the funders are coming to meet me. No way. There are a lot more players in the field, and we must make our brand attractive so that we can attract industry funds. We also need to promote researcher exchange for incubation of ideas and then provide seed funds to early and mid-career researchers. As researchers, we must remain curious. We must not allow the economic hardships. We must not allow the many times we have gotten a no, we cannot fund you, to drive away our curiosity. We must remain curious, continue to ask questions about questions, so that this can promote the conduct of research that has impact. Then self-development also is important. And we must foster relationships with the larger research environment, with policymakers. We should not be shy of working with policymakers. Professor Longe has shown us that we can work with policymakers, industry as well, and then research users. And so in conclusion, adequately funded research is essential for development. And the research deficit is a global concern, and it needs to be addressed in innovative ways. Local and international investment in research is essential for us to develop. It's essential for us to move forward as a country. And we need more local investments for Nigeria and Africa to become a true powerhouse of the future. And addressing the research deficit is not just one person's responsibility, it's a joint responsibility that we all need to commit to. Thank you very much.
Please, can we continue to appreciate all the speakers? Thank you very much for shedding light on this very critical theme, contemporary threats to Nigeria's public health, infectious diseases, flooding, and research funding deficits. So we've heard a lot today. I know that we've dipped our feet into the pool of public health. A lot of us have questions. Please, I want to implore you that if you have any questions, that you should take note of them. The panel session will begin, and we'll only be taking a few questions to accommodate for time. Before we continue, we have very special people in our midst that we want to acknowledge and appreciate. Our past editorial consultants, and we want to recognize and celebrate them because their dedication, their guidance, and expertise have shaped Dokita into what it is today. So on behalf of the Dokita Editorial Board, I want to invite Professor Ogbole to please come and present these awards to our past editorial consultants. Please, round of applause for him as he comes. Right. So Professor Gole is standing here today representing the Office of the Vice Chancellor of the University of Ibadan, as well as the Provost of the College of Medicine of the University of Ibadan. Please, round of applause for him. All right. So the board would like to recognize and appreciate Professor Oguni. Thank you very much, sir, for your dedication, your insights, your expertise. We appreciate you. Thank you so much for all that you've done for the Dokita Editorial Board over these past years. Thank you, sir.
This is a rare privilege and an honor, and on behalf of the Dokita Editorial Board, we would like to present this to Professor Adeshola Oguni in appreciation of distinguished services and for your outstanding dedication, exceptional leadership, and invaluable contributions as an editorial consultant. So it's a rare privilege for me to honor my father and my mentor.
Thank you very much, sir. The board would also like to appreciate Dr. Adeosun. Dr. Adeosun, consultant otorhinolaryngologist, and a very esteemed editorial consultant of this board. Thank you so much, sir, for your continued years of service and dedication. We appreciate you and all that you've been doing for the Dokita Editorial Board.
Okay, another big one. These are our past editorial Dokita consultants. So the Dokita Editorial Board would like to present this to you, Dr. Aderemi. Consultant of the Dokita Editorial Board. It's an honor to give this to you, sir. Thank you so much for serving Dokita.
Thank you very much, sirs. Thank you very much. Please, another round of applause for them. And I would also like us to celebrate all the past editorial consultants who are in absentia. They have worked tirelessly to continue to promote Dokita Editorial Board to all it is today. So thank you very much, sirs and Maz, wherever you are. We appreciate you. All right. So while we are setting up for the panel session, we'll be receiving Professor Olawoye, the Deputy CMAC of University College Hospital, who will be giving us a goodwill message on behalf of the Chief Medical Director of the hospital. Thank you very much, Ma.
The chairman of this occasion, Professor Temitope Alonge, my teacher, a mentor, a geriatrician, a professor, and someone who wears many caps. You know, Professor Longe inspires me in many ways. He not only knows how to mingle at the top, he also mingles down. And when I say that, I mean he comes down to the level of the old men and women as a geriatrician, and he gives back to the community. Please appreciate him on my behalf. Thank you so much, sir. Thank you for all you do. The board chairman, Professor Omigbodo, I call him a fisher of academics. You know, the Bible talks about fishermen. He is a fisherman, but he fishes academics. He brings them out. He inspires them. Right from secondary school, I'm aware of that, to Dokita Medical School, to residency, to doctors all over, to non-doctors, to PhD. He keeps fishing them out. Thank you so much, sir. Thank you for all you do. We appreciate you. My many teachers here present. Professor Oguni, he's looking at me. I met Professor Oguni at a very strange place. I was a very young researcher at that time, and I had brought my research work, and I was trying to compete for a grant. Professor Oguni inspired me. He encouraged me. He didn't know me, but he was just taking, you know, he listened to what I had to say, and it was a small idea, but it was big in his eyes. I thank you so much, sir. Thank you for inspiring us. Thank you, because I know even Dokita has been inspired by you over the years. My many teachers here present, Professor Adeosun, Professor Dukogbe, Dr. Adeleye, so many other people that I really cannot see here. Thank you so much for supporting the University College Hospital. Thank you for your ideas and for inspiring us. I bring greetings from our dear, amiable Chief Medical Director, Professor Jesse Abiodun Oteg. Thank you so much. Today happens to be his birthday. Many years ago, Professor Jesse Otegbayo was born, and just this morning before I came here, we took a picture with a small cake to remember his birthday. Please give him a round of applause, even if he's not here. Thank you so much. I bring warm greetings from him. He has asked me to give his warm greetings to you as Dokita. I am thoroughly impressed by what you're doing. You have kept the flag flying for several years. Many people have come through, and you have just continued. You have made Dokita bigger, bolder, better, and achieving so much more. Please give yourselves a round of applause. Thank you for what you're doing. You keep creating the research environment that we all need. Many years ago, I attended a conference. It was the World Glaucoma Congress. And I'll never forget the picture I had in my mind. It was an African symposium. And on the high table were 5 pure Caucasians telling the story of Africa. And they kept on, you know, from one topic to the other. As I sat in the crowd, I kept asking myself, why are other people telling the story of Africa? These are people who will come into the African continent for a week or two and become experts on our stories. And I remember coming out of that meeting, and I asked the professor that we had gone together, I said, Ma, why are other people telling our stories? She looked at me and said, you will have to pay the price to tell your own story. and I've never forgotten that. And as you all sit down here, you are all researchers in one way or the other. That means you keep asking those questions. Why are things the way they are? What can we do to make them better? How can we improve what we're doing now? Is it even possible to improve? During one of my programs in the US, I met a few people, and they would tell me, this person invented the gonioscopy lens. That person invented, and I found out that they were flesh and blood. They were not demigods, and we all can do it. And so I leave this charge from the Chief Medical Director to all of you here. Begin to ask those questions. Keep asking, keep finding out, keep delving into it. Data is power. And in whatever you do, bring forth that research mind where you keep asking yourself, can it be better? Can we make it better? And don't forget, it is the African story by Africans for Africans. Thank you very much.
Thank you very much, Ma. We will now be delving into the panel session. I would like to invite our three panelists, our wonderful speakers, up onto the podium. Dr. Olukemi Adekonbi, please join us, Ma. I'm sorry, before I continue, please have your questions ready on bits of paper. The ushers will be pointing you out to come to the front to come and ask your questions. Dr. Morakinyo, please join us on the table, and Professor Olumide, thank you so much. All right, so because of time, we'll be spending just a few minutes moderating this session. What would happen is, if you have a question, please raise your hand. If you have a question for any or all of our panelists, please raise your hand. All right, okay, sir. Please, if you have a question in this aisle, anyone in this aisle? Okay, so 1, 2, we'll take 2 questions from each aisle. So 1, 2, 3. Any questions from this aisle? It's not going to be long. So I have a few questions of my own, so I'll just... Is there anyone who doesn't want to come forward and speak and would just like to write down their question? I can give it to the usher. I need just 2 more people, and then we'll begin. All right, so please, those who have questions, please come forward to this aisle on my left, where the usher will give you the microphone to ask your questions, and then we'll begin the session.
Good afternoon, everyone. Thank you for the wonderful lecture. My name is Hussein Adotu, and I have a question first for the infectious disease specialist, and then the last speaker on, that spoke on research funding. So my first question is, what are the drivers of pediatric HIV in Nigeria? You mentioned that Nigeria has the highest burden of HIV globally. So what are the drivers of that? And for the speaker on research funding, so where is most of our revenues on research going into, so that we can look at how we can either cut costs or increase returns of investment in research? Where, like, for a researcher granted funds for research, so what do they spend most of their research funds on? Is it on the research itself, on publication, or the logistics of research? Thank you.
Thank you so much for your presentation. This is for like all the panelists, but specifically Professor Olumide. Okay, during your talk, because I just realized I've always been thinking of research in like a 2D manner, kind of. And you mentioned like about the patents. So I don't know if you know anyone that has successfully gotten a patent from their research, maybe locally or anyone you know, and even if any of the other panelists know any as well.
Thank you for your question. So the main driver of pediatric HIV infection is actually mother-to-child transmission. So what should happen is when a woman is pregnant, when any woman is pregnant, she should present for antenatal care. And there are certain tests that are done. She should be tested for HIV, hepatitis, syphilis, and a few other tests. And then she should also receive some vaccines during pregnancy. So if this is not done, that's what happens. These women don't know that they are infected, so they are not able to receive antiretroviral drugs during pregnancy, and that the child can then be born with HIV. And apart from receiving the antiretroviral medications during pregnancy, there's also drugs that should be given to the child immediately after birth, and then they should be followed up very closely. But because if the woman is not within the healthcare system, the formal healthcare system, while she's pregnant, and she happens to be HIV positive, then you have these high rates. Regarding the question about patents, I'll let Professor Olumide answer that, and then if she doesn't mention someone I know, then I'll mention it.
You can start by mentioning the person that you know. All right, thank you very much. So the first question was asking about what's the bulk of research funds spent on. So usually the bulk will be spent on the research itself, carrying out the research itself. The cost of publication, like I said, it depends, it varies. Some journals will take as little as nothing, depending. Some will take a subsidized amount for people coming from Nigeria. That is, Nigeria is viewed as a middle-income country, and so we'll pay as little as $500. Sometimes we get to pay half. So, but the bulk of the research funds are actually on implementing the research itself. Then the question about patents, I think one that readily comes to mind is someone in environmental health. I think Professor, I'm trying to remember his name now. He developed a type of, I think he developed a sealing board from, I'm trying to remember what material it was. Professor Okare, yeah, I think it's Professor Okare. So he developed a type of sealing board from, I think it's a reusable material. That's the one that comes to mind readily. So you can mention.
Okay. I believe Dr. Afi Michael and Professor Lawal, current dean, have a patent for like a post-op or intra-op warmer so that the patient doesn't get hypothermic during surgery. I also think Professor Jengbede, who retired about 5 years ago, has a patent for a device that's used to mitigate the effects of postpartum hemorrhage, where a woman who's giving birth in the field, not necessarily in a hospital or in a poly-resourced hospital, when she loses a lot of blood, it's the way they can save the blood and return it to the mother. And those are the two I think of right off the top of my head.
Okay, just to add to the list, just like Professor Olumide mentioned, I'm in the Department of Environmental Sciences, and so we have senior colleagues who have developed patents on various projects, and the late Professor Okay, the late Professor M.K. Suchida, Professor Anna Oloruntoba, and a host of them have developed patents from their research. So there is an office in UI, I think the one headed by Professor Arulugu, the Center for Entrepreneurship and Innovation, and also another center where currently Professor Kari is the director. They handle issues related to patents. So if you need further information, you can meet me. I will direct you as appropriate.
All right, thank you very much, Sir Amaz. Next question, please.
Thank you very much, Ma. My first question is for Professor Olumide. So, Ma, I would like you to correct me if I'm making a mistake. I used to believe that research should stem from problems, then fundings can come after. But recently, is requests for proposals that bring about researches. Has that affected the quality of research in any way? And also, I want to ask Dr. Morakinyo a question. Is funding a problem in flooding? Because you mentioned that the leaders don't normally attend the preventive measures meetings. So even if we have enough funding, are we willing to do the work? And also, I want to ask that, have we ever had anything put in place that worked effectively to prevent funding? Is it that we had it at some point and then it stopped working, or we never had it at all? Thank you.
Is there any other question? Okay.
Yeah, I will take last.
All right, good afternoon. Thank you for the wonderful session. My question is, you talked about most of our research focusing on education, like medical student research focusing on education and all those stuff. But how are we going, taking the situation of the country or Nigeria itself into consideration? How are medical students going to be participating in groundbreaking research? Like maybe some research that require serious lab work. So, our lab in this side of the world is not that standard enough for such kind of research.
Yes. Yeah, and thank you very much. My name is Joshua Alabi. Just want to cap off this session. I don't believe that we have any more questions. Someone wanted to ask that how do we engage the government more in research? And to cap off what the question he asked, how do we as medical students tap more into this funding? Because we understand that we have to toggle medical school. Our primary focus in medical school is going to classes, but how do we now go about this research? Getting grants, writing proposals on top of school work, and how do we effectively and efficiently get into this funding? How do we tap into it that it doesn't really negate the other aspects of our education? Thank you very much.
All right, thank you very much, Azabaz.
Thank you very much, Ma. My question is primarily as regards the collaboration between research organizations and, between researchers and the private sector. How do we avoid conflicts of interest, especially we've heard things like conflicts between pharmaceutical companies and FDA regulations in places like the US, where big pharma heavily funds research in terms of things like that. While we don't have infrastructure like that here, if we're intending to shift towards funding from the private sector, how do we avoid conflicts of interest, avoid pandering to, avoid data fabrication that would support the outcomes that would promote the services of these companies, considering the fact that Nigeria is particularly not known for strict regulations. My second question is as regards self-funded research. You mentioned a lot of research opportunities. Of course, there's a high chance, the chances that you will get funded by those programs, especially as a student, might be slim. So but you've mentioned as well that the costs for publication can be quite steep. So what happens when you might have to fund, you're at a point where you're realizing that you may have to fund your project yourself? How do you go about a thing like that?
Okay, thank you very much for your question, and the question is with regards to funding for flooding. I would like to say that I think the fundings are there, but it's just the attitude of our leaders, their priorities to issues of flooding. People believe that is after the deed has been done that they should respond. So oftentimes the issue of being proactive, putting in place measures that will forestall the flooding from occurring in the first place are not things that we do. For example, over the years we've been talking about dredging, the River Niger, River Benue, construction of dams and so many other things. We know that those things should be done, but nobody is doing anything. But once the flood comes, we make so much noise, put in place some initial measures that can curtail the flooding, and off we go till another time. So they think that the funding are there, but just the priority, our attitudes to things that affect us.
Okay,
I'll attempt to answer some of the questions. To the issue of how to engage government in research, one of the things we have to do as professionals is advocacy. So there are many different avenues for advocacy. We can go through professional societies. So, for instance, the Nigerian Infectious Diseases Society plays a significant advocacy role, and we meet with leaders in government, so governors, Senate members, House of Rep, to talk about problems that are important in infectious disease. So we try to advocate, and we try to establish ourselves as the local experts. And so if anything comes up, they end up reaching out to one of us, and we try to, and then we use all those opportunities for advocacy. When talking about how does a student get involved in high quality research, it'll be challenging. That's the truth. What I would advise is that you find a mentor who's a faculty member in research and work along with them. I don't expect any student to be applying for grants. To be honest with you, some students have applied for grants successfully. These are very small grants, and you can carry them out along with your work. So nothing crazy. We're not asking you to apply for $1 million grant, but people are getting grants of $500, $2,000 in groups, and they're able to do this work. They're able to do the work. So you guys are already doing it, but we're not talking about big grants that we are supposed to be applying for, but things that you can apply for. So it's possible. But if you just want to learn the experience, you can work with if you know a faculty member that's doing something you're interested in, you can approach them and see if there's anything you can work on. And then they might give you maybe they've collected some data, they've analyzed it, they've done what they want to do with it. And then they might give it to you and say, can you think of any questions you can answer with this data set? They can walk you through the data set, and you focus on maybe analyzing the data and so on and so forth. And then with regard to how to avoid conflicts of interest, how to avoid data fabrication, that one is easy. Don't do it. Simple. There's what we call ethics in research. There are certain things that, you go through your group clinical practices training, ethics training, you should before you do any form of research. And there are some things that will be clearly spelled out that you should not do, especially when you're engaging with pharma. When it comes to pharma, it's better to do investigator-initiated studies. So they'll say, we have $5 million and we want to support 10 researchers. And we want you to work in these fields. So maybe antimicrobial resistance. They're not even telling you whether it is AMR in TB or in gram-negatives or gram-positives. You are the originator of the idea. It's difficult to be influenced. They're not going to influence you in any way. You write a proposal, and all they do is yes or no, whether they're giving you money. They don't interfere. And you should try to do that. But there are also pharma-supported studies when they're trying to get their drugs approved. You can get involved in those kinds of studies, but what feels bad does not feel right to you is probably not right. Engage your seniors, your colleagues, and discuss things that look like might be a bit of a conflict. If there are any gray areas, talk to people in CREAM, talk to Professor Olumide. She can probably tell you, this doesn't look right, this doesn't sound right. But if you just use your internal barometer, and I'm assuming that your internal barometer is okay, use your internal barometer. If anything doesn't feel good, and not only in research, in life in general, don't do it.
All right, thank you very much. Thank you very much for that very apt answer, Dr. Adekombi. People have been working with Big Pharma for years, and like Dr. Adekombi said, use your internal barometer. But then beyond that, there are also ethics of research that it will be difficult for you to go against those ethics. If you are working in a pharmaceutical company as a researcher, it's quite different from if you are working outside the pharmaceutical company. Outside, if they engage you as a researcher, they expect you to do the research using the correct methods, and then you submit your report. So you have done what is right. Beyond that also, usually if you are working with them, you do have to sign agreements. And so maybe I can say this because I work in the research management office. We don't encourage people to go on their own and start to sign those agreements, because as a researcher, you are always biased. You want the money. You want to do the science. So when you have someone from a research management office looking at that agreement for you, they can spot the pitfalls or the pitfalls and the loopholes and tell you that these are the things that you need to avoid. Also, with most big, large-funded studies, they expect you to have a data supervisory board, a community advisory board. So all those boards are overseeing the types of work you are doing to ensure that there is, for want of a better word, there is no hanky-panky in the way in which you are collecting the data. It is if you as a researcher do not have sound research methods and you try to compromise at that point, that your results could be found wanting. But if you use the right research methods, you follow all the principles of working with large industries for conducting this research, you follow all the ethical principles, the odds that your findings are going to be misinterpreted are very slim. I think talking about how medical students can be involved in research, everyone has said this. So primarily, you're in medical school for the medical education. I think what then needs to be done is to intentionally develop a program for the researchers of tomorrow, today. That way, you have dedicated time to work on research. Until then, you have to look for various avenues to do as much research as you can do. And there are actually some avenues in place. I know when you are doing your obstetrics and gynecology posting, you're supposed to do a small study. That is research. But what happens is that usually it's done in a group. Those who are really interested end up doing everything, and others are just, their names are just added to it. And so if you know that you are really interested in research, when you're doing your O&G posting, speak up and say, oh, I have this idea I would like to work on, and usually you have a consultant who's attached to your group and you can work with that person. Also, when you are doing your community medicine posting, you are taking through preventive and social medicine posting. You are taking through epidemiology, statistics, research methods. That is also preparing you to be able to do good research. And when you go to Igora, usually you do some research. But as always happens, it's a group of people. Those who are really into it will do the work, and the others just kind of float by. So if you are interested, please use that as an opportunity as well to improve your skills. Then for your outside posting, I'm aware that currently some people can choose to do their outside posting with specific faculty who are working on research. I know some people have worked with, I think, Professor Owolabi, Professor Akiyemi at IMRAT. They've worked with them on their research, and they have been able to do research. So those are different ways in which you can get involved in research. With respect to applying for funds, Dr. Adekombi has said it. You can get those funds, but the odds of a funder who does not know you giving mega funds to a student are slim. You probably must have an Albert Einstein idea. And even then, they want it tied to your institution. So you can work with your with senior colleagues. If the idea has something to do with hypertension, there is definitely a consultant that you can talk with who works on hypertension. You can talk to him about that idea and work with it. Even for early career researchers, many times they don't give them big funds. Everybody wants it to be tried and to be tested. And so I think this is probably a call to our institution as well to develop a pathway for research tomorrow to start today, so that everybody can be a part of it. I think there was a question about, do the funds go before the research, or does the research question come before the funds, or does the funds come before the research question? So sometimes you might see you might see a call for funding, and you have an idea. You then develop your idea for that particular funding. And it can happen the other way around too. So either one, it can either be the funds before, well, you might have the idea before you see the call, and sometimes you see the call before you have the idea. And so either one of them can come before the other. I think I have gone through everything I have here.
Thank you very much, Sir Mas, for your responses. This has been a very insightful conversation, and we appreciate you. Please give them a round of applause. Thank you. So to cap off this panel session, I just want to ask, just for one word of advice to our future researchers, the medical students here today, what would you want to, just one word, yes, that you want to say to us?
Follow your passion. I know that's not one word. I'll say follow your passion. Do what you're really interested in, because you will probably end up doing it really well. Don't think about the money. If you do anything really well, the money comes. Follows you.
Okay. Thank you very much, Ma.
Okay, I would like to say be persistent in what you are doing, whatever you are doing, be persistent, be committed, and be dedicated.
Thank you, sir. All right. You kind of took that one from in a different way. So I was going to say it's doable. So that's really like be persistent. It is something you can do and follow your passion.
All right, thank you very, very much, Sir Amaz. Thank you so much for having this panel session with us. We appreciate you. Thank you for the lectures today. Have we learned something? Okay, all right. We're leaving this place richer than we came, because, as they say, data is power, data is wealth. So now we'll be taking the up-to-date presentation. We have in our Miss Dr. Ajuan, the medical librarian of the Latin de Odeku Medical Library. Please give her a very warm round of applause. So she'll be giving us a presentation on up-to-date.
Good afternoon, sir. Professor Lange, Professor Olabi, Professor Gweli, Professor Adeweye, representing the CMD. Our great presenters of today, thank you so much for the wonderful presentations. Professor Dukogwe, Dr. Adeoshun, and all other academic staff here present, the Dokita editorial team, students, the representative of the secretary to the college. I am so delighted to be here today. One thing I ever love to do is talking about up to date. In whatever forum I find myself, I want to talk about up to date. And what is up to date? Up to date is a clinical decision support tool. We know about Severe Science Direct. We know about ProQuest. We know about Scopus, Web of Science, and all others. And what do we do with that? They give us access to the published literature. But up to date, give us access to clinical information. Before the year 2020, some clinicians came to me and said they need access to up to date. It's expensive, we could not afford it. So I started looking for a way of how we can get it free of charge. And we got 5-year free access from 2020 to 2025. But you know what? It's not being used. By next year, that subscription is going to lapse. It's going to lapse. Each time we get the statistics of usage, it's always 20%. Despite the fact that we have students, MBBS students, BDS students, clinical students, nursing students, physiotherapy students, BMLS students, they are not using it. It's not being used. I have done my bit. So what we have decided to do is to use students like you to reach you. So we have decided to have up-to-date champions in the College of Medicine. Up-to-date champions among you. So we have here Alabi Joshua, Ayeni Samuel, Olawi Dimeji. We have not been able to find someone in the 2024 set. I need someone. So in this regard, I'm going to call Alabi Joshua to give us the up-to-date presentation. He's a good up-to-date user. Thank you very much.
Thank you very much. Standing on existing protocol. Yes. Thank you very much for giving me this opportunity to present this. As the librarian has rightly said, up-to-date is a very, very useful tool in your journey as a researcher. Just imagine Medscape. Just one thing about being a medical student, when I'm presenting academic literature, there's something that they always say, put your references, and it needs to be high quality. It needs to be something that is done, like something you see like within the last 5 years. But up-to-date has made everything like that so easy. The normal pricing for up-to-date for a regular person is $500. For a medical student, when you put the pricing like this, you can save up to 50%, so you can pay just $110. But the College of Medicine UI has made this completely free. Completely free. All you just need to do is to register
under the College of Medicine, and you have access for it for, I think, up to 2 years. You don't even need to register again. Just have complete access. You can download the app, download this on your phone, and you have constant access to this up-to-date information. It's updated regularly, so you have easy access to it. So what is up-to-date? A clinical decision support tool by 7,000 world-renowned physicians. Over 1.9 million clinicians and over 190 doctors rely on up-to-date. Every day, clinicians view topics 1.6 million times to show that this is a tool that is widely used. 300,000 medical decisions daily are impacted by up-to-date. It provides change, they are provided by change 30% of the time. There's remote access from any computer. It gives you CME credits. What are CME credits? Continuous education. That means when you access this, it gives you points that you can redeem to show that you actually learned this thing. You can bookmark, you can see your history, you can automatically sync your history. Like I, for one, I use it on my PC, I use it on my phone, I use it on my tablet. So anytime I need updated information, I mean, I sound like a broken record now, I'm saying up to date. Every single time it's being updated. It's being updated. So you know that there's a bi-weekly e-newsletter with important clinical updates from the editorial team. So how do you register? Just simple. It's very, very simple. All you just need to do is connect to the college Wi-Fi, open the website, that is uptodate.com/online, click on register, fill in your information, click on submit. Simple. That is all. It's so simple, and this is free. They are accessing data, they are accessing information that is worth $500. So it's free. And if you forget your password, just click on forget username and password, and that is it. So you just download the app, update it, and just log in. And that is our access up-to-date for free. So you can just scan this right now to download the app. And to make it easier for all of us, to make it easy for the student body, we at Dokita have come together to bring all those up-to-date champions. These are students that are beside you, students that are near you. They will be at the library for a set time. You will just go there, tell them that you want to register, and they will help you to register free of charge. $500 worth of data, free of charge. Aren't you happy to be here? So these are the people that are involved in this program. You can just scan this app, download this app. At the end of the symposium, there will be people in the library. Just walk into the library and say that you want to register for up-to-date, and there will be some of these up-to-date champions will be there in the library to help you register. Thank you very much.
Ladies and gentlemen, another round of applause for Mr. Joshua Alabi, Productions Manager of the Dokita Editorial Board and up-to-date champion. All right, so just when you leave here, straight to the library, tell them you want to register for up-to-date and access your goodies, your free goodies. Now we'll be unveiling our Dokita Journal, the 41st edition of the Dokita Journal. But yes, it's very exciting. But before we go ahead and do that, we'll be taking a brief review from Professor Mayowa Owolabi, a professor of medicine and a consultant neurologist here at the University College Hospital Ibadan, an avid researcher and world changer. Please, sir, thank you so much for joining us today. Thank you for gracing us with your presence.
Thank you very much. Thank you so very much, and congratulations. I want to stand on existing protocols and acknowledge my teachers, mentors, some of whom have left the room, and some of whom are already given some plaques, and of course the speakers, those who have already spoken. But I think this is the highlight of this event today, celebrating scientific communication, which is really the lifeblood of communicating ideas, theories, solutions to problems by scientists. Scientific communication through publication is a pivotal element of the scientific endeavor. Throughout today, a lot has been said about how science has changed the world and has continued to change the world by advancing the frontiers of human development through discovery and application of discoveries of natural laws as aspects of universal reality and truth. Science is about the truth. And medicine is at the intersection of the science and the arts. While science provides the evidence supporting assessments, diagnosis, prediction, prognosis, prevention, treatment, rehabilitation, and care, humanities provides the basis for the relationships, the ethics, the ethos, the value systems, the purpose and philosophy of medicine. And academic journals are extremely important as the fora for not just intergenerational communication, but also international, interdisciplinary communication, cross-pollination of ideas, discoveries, hypotheses, theories, questions, methods, and solutions by scientists for the world. And we all know that right now, advances in medicine are occurring at a dizzying speed with information explosion. Old methods and treatments are fast becoming obsolete. So much so that many things that you are taught today, in 5-10 years' time, they're completely obsolete, replaced by better interventions. Things that were like science fiction before, diseases that are seemingly incurable or non-predictable, over time we'll be able to overcome them using the tools of science. So scientific communication, despite the fact that the medical curriculum is already overcrowded, scientific communication is an essential and critical ingredient of the medical curriculum. And therefore, I massively congratulate the pioneers who envisioned Dokita, the first medical students journal in sub-Saharan Africa, to fulfill this key aspect of the medical curriculum, to stimulate scientific inquisitiveness among students and teach them the arts of scientific expression, as arts is about expression. So I really congratulate you. So I commend you to digest the 41st edition, which is the general edition, introducing diverse topics, including women health, breast cancer, gestational diabetes mellitus, hormonal contraceptives, abortion, gender-based violence, mental health, including autism, electroconvulsive therapy, transcranial magnetic stimulation, mental health of health workers, and others. I will just run you through a few of the articles. They're actually narrative reviews, which is a good way to start. But of course, meta-analysis, systematic reviews, and what is now known as umbrella reviews are welcome in future editions, and actually original data are also welcome. So transcranial magnetic stimulation is actually an old method which is resurging, so to speak, and is finding use not only in neurology but also in psychiatry. So there's a review article on that that talks about its utility in major depressive disorders, obsessive compulsive disorder, and smoking cessation. So if you want to know more about this, I commend you to look at the first article starting from page 1 of this journal. Then comes the impact of hormonal contraceptives on the mental health of reproductive age women. And some of these are highlighted, including risk of depression, mood disorders, and a few other conditions, which needs to be taken into cognizance while using different types of contraceptives. Adolescent autism in Nigeria, prevalence, factors and recommendations. This starts from page 12 and highlights the high prevalence of autism spectrum disorders in adolescents, and the underlying factors are complex and interrelated. Actually, autism spectrum disorders, the incidence and prevalence have doubled over the last few decades. So we need to really understand why this is happening. What are the drivers, the commercial, the social determinants of that? Then next is unmasking the barriers health workers experience with reporting gender-based violence. Here, gender-based violence is X-rayed, and the role of health workers as often the first responders is also highlighted. And the barriers encountered in performing this role, including jurisprudential, financial, sociocultural, spiritual, and institutional barriers, as well as lack of institutional protocol and training, fear of breaching confidentiality are highlighted. Next comes medical versus surgical management of incomplete abortion. a literature review. And the highlight of this, of course, weighing the pros and cons, and then looking at the perspective of the end users. More women preferred medical method because it's less invasive, and it is actually more confidential and private. However, gynecologists prefer surgical method because it's more effective with lower complication rates. If you're interested in the details, please go through pages 22 all the way to page 27. So next comes electroconvulsive therapy, which is an historic intervention for several mental health disorders, including severe depression, bipolar disorders, schizophrenia, and catatonia. It's still found to be useful, including in non-psychiatric conditions like Parkinson's disease, but it has its own side effects like temporary confusion, memory loss, and physical discomfort. So highlights of these are included, starting from page 28. Breast cancer is reviewed in Nigeria, the prevalence, the management, the survival outcomes, quality of life, including the WHO Global Breast Cancer Initiative, with a target to reduce mortality by 2.5% per year by prevention, early diagnosis, and treatment. So the next condition is on the prevalence of mental health problems and associated factors among healthcare workers. This is extremely important because it applies to all of us. Healthcare workers have a higher than normal prevalence of these conditions. And examples are the post-traumatic stress disorder, anxiety disorder, and major depressive disorders, and acute stress disorders. And there are factors that contribute to this, including bullying, burnout, the nature of the job, the working hours, marital status, remuneration, and recommendations are made. So you can join me in going through pages 35 to page 39 to really understand this. And this is recommended for all clinicians. Then comes the impact of management of gestational diabetes mellitus on pregnancy outcome in Africa. Also, this is a narrative review and talks about the consequences of gestational diabetes, including preterm delivery, preeclampsia, macrosomia, and hypoglycemia in the fetus or in the children, in the neonate, and how this can be dealt with or prevented. So pages 40 to page 43. And then a short history of the early years of Dokita, which transmuted from just a magazine, Hamatan magazine, to becoming the first medical students journal in sub-Saharan Africa. Again, congratulations. We are all experiencing hyperinflation in Nigeria, and what is becoming more and more obvious is that the reductionistic approach to medicine that is entirely biophysical or biomedical is beginning to change because it doesn't answer all the questions. The molecular, biomolecular doesn't answer all the questions. We are beginning to realize that disease causality is influenced by political, legal, ethical, anthropological, socio-economic, and commercial factors. And so it's worthwhile selecting hyperinflation and discussing and dissecting its impact on the Nigerian health sector, which is multifaceted. So for that, you need to go to page 45 all the way to page 48. Then interviews with Dr. Oluwafemi Agbayewa, that's from page 49. Very, very extensive. All the way to page 61. And then another interview with Dr. Olaleye Oladejo. So, and those are really very encouraging and inspiring and worth reading. Of course, remember that I started by saying medicine is at the intersection of the science and the arts. So you see a lot of arts, including a painting of a lady. That's on page 68. And then you see poems, Break the Silence, a letter from a woman to another woman, The Man in White. So you see poetry, beautiful poetry, silence. And then you see an interview, a debate on vaccines, which is actually like a screenplay, so to speak. And then comes alphabetic romanticism. Again, this is the beauty of art in medicine, and famous chess puzzles. So all the way, of course, then you see Sudoku puzzles, you see pictures, the college news, and all the way to the last page, which again reinforces the fact that Dokita started in 1960, the same day or the same year Nigeria gained independence, to give freedom and independence to students to explore the realms of science and provide solutions to problems, even starting from the very young age. So congratulations, congratulations, congratulations.
Thank you very, very much, sir. So you can see that there's a lot to look forward to. Are we ready to launch? Let me talk to the board members. Dokita Editorial board members, are we ready to launch?
Yes.
You people have worked hard. So the 41st edition of the Dokita Editorial Journal will be launched by the chairman of the symposium, Professor Temitope Alonge. Thank you so much, sir, for doing this for us. Please continue to give him a round of applause until he gets here.
Thank you very much. This is not my closing remarks. I'm looking for the editor-in-chief to come and sort out this last bit. Editor-in-chief, come. Now, for ease of payment and in line with technology and AI, I have been given this QR code. Look, I've scanned, I've made payment, but I want to go and paste it. It's not pasting there. Yes, I tried to download it. It's not, maybe the internet is hanging. Okay. So, I've gone all to the point, I've made payment. I was just going to download the receipt and go and paste it on the app that was created. So simple. So all you need to do first is to please scan the QR code on your phone. Scan your QR code, and then you follow the instructions up to the point where you make payment. But I think the internet here is hanging, so I can't download. But I've got copies from my for the Department of Orthopedics and Trauma Library. I have to give to two other libraries. Now, the unit cost, if Professor Dugogbe's phone is not getting the QR code, it just tells you his age. So he's not in this current age. So it must be an Android phone. I will take it. We'll give it to them in the college for a replacement, since he's the head of Department of O&G. So the unit cost, I'm told, is 10,000 a unit cost. That's exceptionally cheap. 10,000 for the unit cost. And I've done my own launching. I've got my copies. So, Professor Bole, have you downloaded your QR code? Go ahead, download it. Professor Owolabi, download your QR code. You can pay us in dollar equivalent of the 10,000. And Professor Owolabi is taking 5 copies. He's taking 5 copies. It's his edition now. It's Neurosciences edition. So he's taking 5 copies. I didn't need his permission. So you can download the QR code. But for all the speakers on that side, there will be two copies. But the CMD of UCH, ably represented. You want me to list the departments in UCH? No, do I list them for the public hearing, or we should keep it to ourselves? Okay, all right. So make your promise. Okay. Professor Olawoye has promised to speak to the CMD, and I believe her when she gets to see him, telling him that it's 10,000 per copy, and we don't sell less than 10 for an institution. We can't sell less than 10. And UCH has 64 departments. For the retirees, wait. Retirees don't have too much money. And he has a big estate of farm that will bring money in. So whatever he agrees to do, take it. But for Professor Dukogbe, and about 3 or 4 topics there that are OBGY. Prof, you have more than 5 topics that are OBGY. So it means your departmental library, your personal library, which other library? Your wife's library. So Professor Dukogbe will not take less than 3. So let him pay for 3. The consultant in the house, public health. You cannot pretend by looking down. That's the HOD of public health. Go and give him the QR code. He's going to pay for himself, his wife, and for his department. That makes 3 copies. I'm not going to ask my endocrine sister because she's going to come up stage. She knows what to do. Abi Sister Joko. She knows what to do. So I'm not going to harass her. Now, medical librarian, you didn't tell me up to date when I was a student. I never, in those days, those of us who come from very poor homes, we come to the library to sit down to read from morning to night because there's no textbook. I couldn't afford a textbook. Can you imagine if up to date was available then I'll be sitting down and enjoying what I'm supposed to enjoy. So if you don't take advantage of up to date, you have yourself to blame. Maybe we can access it and I will ask questions from up to date. Abi, if you give me the privilege, I will make sure I have orthopedic related questions from up to date just to know whether you are up to date. Abi, for your own good, I will make it very public once my voice improves that all the consultants should use up to date. So if we give you questions from up to date, it is because we are up to date and you are the ones who are not up to date. Thank you for the information. Please avail yourself the copies of this particularly a wonderful journal. And for those who are pestering you with questions, start from Dokita. Start writing from Dokita. You learn the tricks and the trade of publishing. It's an art. The more you do it, Professor Wolabi has hundreds of publications. You should tag to him and ask him. Okay? So there's a system by which we publish. But when you start small, then you can go up. Don't be looking for $300,000 grant. You will never get it to as medical students. But you can start, you start small, you meet your mentors, they will teach you. The moment you're able to publish well-researched journal in Dokita, that's the beginning of your career, growth. I told you my first paper was published in Dokita, and I'm hoping very soon I will get to hundreds as well. It is still very small. But the bottom line is you start small. So I want to encourage you to start and start now. So how many students are willing to buy? You can save your, what is it called now? The money you spend for, what do you spend money on now? Food. No, not food. They don't spend money on food. They spend money, They spend money on internet access. Up to date is free. But I hope that you're going to get a copy for yourself and it will do you good. Thank you very much.
Thank you very much, sir. Thank you so much. How many students are getting copies of Dokita's 41st edition? Show of hands. Don't let me call you out. Some of us, I know our tax brackets. I know how much we're spending. I see you at Leke in the night. I do. That's just 3 shawarmas, 2 chicken and chips, 10,000 naira only. So I've been asked to inform the House, I've been asked to inform students that only UMSites who have completed their UMSite dues will be receiving the copy, so you can pay, but please make sure that you pay your UMSite dues as well. Thank you very much. You can see what UMSA is doing. We can see what Dokita is doing. Let's invest in our people so that we can continue to reap the rewards of our investment. Now, this program can't be complete without the reason why some of us came here. Some of us are only here to find out the winners of the biennial essay competition, right? Right? Like some people don't even know that that's why we're here. But yes, so before we start, I will be taking this I'll be taking the citation of Professor J. Adeleye. That's the titular character of the competition. This is the 10th edition of the biennial essay competition. His family has been sponsoring this essay competition for the past, that would be what, 20 years now? 20 years. And so Professor J. Adeleye is a distinguished academic, clinician, and leader in the field of obstetrics and gynecology with a career spanning decades of remarkable achievements. He was born on April 8th, 1933, and pursued his secondary education at CMS Grammar School, Lagos, where he held leadership roles as a school prefect and house captain. He continued his academic journey at the Nigerian College of Arts, Science, and Technology, Ibadan, and subsequently at the University College Hospital, Ibadan, earning an MBBS degree. Professor Adeleye undertook postgraduate training at renowned institutions, including the University College Hospital, Ibadan, and several hospitals in Birmingham, UK. His professional qualifications include the Fellowship of the Royal College of Obstetricians and Gynecologists, the National Postgraduate Medical College of Nigeria, and the West African College of Surgeons. Throughout his career, he served in pivotal roles, including professor and consultant at the University of Ibadan and University College Hospital, Ibadan, where he also chaired the Department of Obstetrics and Gynecology from 1988 to 1991. Professor Adeleye's legacy includes over 70 publications in international and national peer-reviewed journals, contributing significantly to advancing maternal health and research in Nigeria. A recipient of numerous awards, he was honored with the prestigious national title, Officer of the Order of the Niger, in 2011 for his outstanding contributions to national development. His leadership as chairman of the Dokita Editorial Board from 1986 to 1992 led to transformative progress, earning him honorary membership in 2006 and the establishment of the annual Professor J.A. Adeleye Essay Competition in his honor. Professor Adeleye's dedication extended beyond academia to administrative excellence, exemplified by his tenure as chairman of the Board of Management at Obafemi Awolowo University Teaching Hospital from 2005 to 2007. Recognized for his leadership and teaching prowess, he received the Best Lecturer Award at the University of Ibadan in 1989. In addition to his academic and professional commitments, he played active roles in organizations like the Society of Gynecology and Obstetrics of Nigeria, serving as chairman of its Western sector from 1993 to 1997 and contributing to its council from 1980 to 1997. His influence is felt nationally and internationally, having participated in numerous conferences, seminars, and as an examiner in medical education. Professor Adeleye's enduring contributions to medicine, education, and national development reflect a career defined by excellence, dedication, and service to humanity. He is an honorary member of the Dokita Editorial Board and the longest served chairman of the Dokita Editorial Board. The biennial essay competition is always held in his honor. And now I would like to invite his daughter, Dr. J.O. Adeleye, to come and give us a few words before we announce the winners of the biennial essay competition.
Chairman of the occasion, Professor Alonge, Board Chairman in absentia, Professor Akiyinka Omigbodun. Distinguished speakers, I thoroughly enjoyed listening to you all. Dr. Olukemi Adekambi from my department, Professor Adesola Olumide, we go a long way. And then Dr. Yewale Morakinyo, well done, I enjoy. Distinguished profs on the high table, Professor Ogbole, Professor Olawoye, Professor Olabi, distinguished members of the Dokita Editorial Board, senior colleagues, medical and dental students, other students here present, distinguished ladies and gentlemen. I have a very brief message from my dad. He's 91, so he would have loved to be here, but he cannot. So I'll just give a very brief message and I'll read it. It gives me great delight that the Dokita Editorial Board has kept the annual symposium, the Dokita Journal, one of which will be launched today, and the annual Professor J. Adeleye essay competition going through the decades gone by. The essay competition was instituted in 1990 by the Editorial Board of Dokita, and it was named after me as a mark of honor for being, as at then, the longest serving editorial board chairman, and in recognition of the tremendous progress made during my tenure. That this has kept going is a testament to the dedication, the diligence, and commitment of successive Dokita Editorial Board members, the chairman of the board, as well as the faculty, staff, advisors. I congratulate and appreciate you all. The essay competition aims to encourage and reward creativity, critical thinking, and academic excellence. If there were no submissions, there would be no competition. So I commend every single medical student and dental, if any did submit, who submitted an essay, an entry to this essay competition. To the brilliant, creative, and resourceful students who participated in the essay competition, I extend my warmest appreciation and recognition to each and every one of you. Well done. To the winners whose names will soon be announced and given due recognition, I offer my hearty congratulations and salute those of you adjudged as the best of the best. To all the faculty who read through the essays and graded them, I say thank you. I encourage you all to continue, you students here, medical students, and other students here present. I encourage you all to continue to strive for excellence. It is my hope and prayer that you will continue to flourish in all your academic pursuits. And to the Dokita Editorial Board, may you go from strength to strength and continue to strive for the excellence Dokita is synonymous with. I wish you all a successful annual symposium and journal launch, where that has gone successfully. God bless you all. Thank you.
Show you the slide, so because I'm actually one of the winners, the person who took first position, the second,
Oh, no problem. Okay, that's the. surname, first name, it doesn't matter. Just read it. Okay. So it's time to present the awards to the winners of the essay competition. And in third place, we have Joshua John Iniolua. Come right out, please. Congratulations. So this award is being presented to Mr. Joshua John Iniolua, soon to be doctor. This award of excellence by the Dokita Editorial Board for emerging the overall third position in the 10th biennial Professor J.A. Adeleye Inter-Medical School Essay Competition. Congratulations. And in second place, we have Mr. Ugo Benedict. Where are you? The plaque says Award of Excellence presented to Mr. Ugo Benedict, soon to be doctor, Abi, for emerging the overall second position in the 10th biennial Professor J. Adeleye Inter-Medical School Essay Competition. Very well done. And the first place is going to be awarded, or is awarded, to Mr. Bello Hussein. Soon to be Dr. Bello Hussein. So this award of excellence is being presented to you for emerging the overall first position in the 10th biennial Professor J. Adeleye Inter-Medical School Essay Competition. Congratulations. So congratulations to all the winners. And if you sent in an essay but you didn't win first, second, or third place, I still congratulate you. You took part, and there are greater things lying ahead of you. Well done, everyone.
Thank you very much, ma'am. Once again, congratulations to all of our winners. Congratulations. That could be you next year. And trust me, was the only plaque they collected. You can go and meet them later to just find out what could be yours next year. So we're about rounding up, but we have very special people that we also want to acknowledge and appreciate. Our very wonderful speakers today. Thank you so much for the insight that you brought, for the fresh perspective that you brought on the topic of discussion today. We want to award you some plaques. Just want to give you a token of our appreciation. And so I would like to ask Professor Gole on behalf of the Vice Chancellor of the University of Ibadan to come and present the awards to our speakers today. Can we have the award?
All right, thank you so much. And I think we have some great speakers today. And the first person I'm going to be presenting an award to, somebody that told us that misinformation is a virus, or is worse than a virus. So Dr. Olukemi Adekombi, for an excellent presentation. Second speaker goes to another friend of mine, or who takes care of adolescents and wants all of us to be community physicians or global health experts, Professor Adeshola Olumide. Congratulations for an excellent presentation. Okay. And to one of the last, but not the least speaker, who gave us a talk about flooding. And I was told that if people try to save from paying for wastage or their waste by pouring dirt into the drainages, I hope we will stop that in Ibadan. Let's welcome Dr. Oyewale Morakio. So you will agree with me, we've had excellent presentations. Thank you very much.
Thank you very much, sir. Please round of applause for them again. Okay, so we're wrapping up very quickly. All right, sir. Please, we would like you to give a goodwill message from the VC and the Provost.
Okay, thank you very much. And I just want to say that it has been a wonderful afternoon, morning and afternoon. This symposium has, on behalf of the Vice Chancellor and the Provost, I would like to thank the Dokita Editorial Board for what they are doing. Interestingly, I am also a past Dokita Editorial Board member. And I would like to congratulate you on this in a wonderful effort of what you have put together. And I believe that what you're doing here will set a stage for the future of research in Nigeria and beyond. The University of Ibadan has been the first and the best, and I think you guys have been trailblazers. And I want to wish you well and congratulate even the editorial board members that are leaving and those who are coming on board. And also to congratulate the board chairman for doing an excellent job. And I want to thank Professor Alonge for being a supportive member of the Dokita Editorial Board. And I want to also say that you guys have done well by selecting one of the finest speakers to make presentations to us this afternoon. So congratulations. Thank you very much, Dokita, and have a wonderful year, and I look forward to another great event on behalf of the Provost and the VC. Thank you very much.
Thank you very much for honoring us, sir. All right, so as we've seen, we already honored our past editorial consultants, but we have new editorial consultants that we want to announce, and we want to acknowledge them and appreciate them. So I'll be inviting the editor-in-chief of the Dokita Editorial Board to come and announce these new editorial consultants. Please round of applause for him as he comes. Encourage him. Thank you.
Thank you very much. Hello, everyone. I trust we're all having a good moment today. So I'll be going ahead to announce the new sets of editorial consultants that will be serving the board. Please, as I mentioned their names, please can we all do the honors of, clapping for them, like really, really clapping for them, because these ones have taken time out of their busy schedule to really impart and to encourage and contribute to the progress of the students. So I'll be calling on Professor Olubukola Additional is currently serving as the chairperson of the Medical Advisory Committee of the University College Hospital, consultant, professor of obstetrics and gynecology. I'm also calling on Professor Mayowa Ohulabi. Third person, Professor Godwin Ogole. And then, fourth person, Dr. Ayodeji Matthew Adebayo, currently serving as the head of department, Community of Medicine. Please, can we clap for them, please? These ones will be imparting us to be contributing. Trust me, these people are very, very, very busy and difficult to catch. But these ones have taken time to honor our invitation. So please, do honor them. Thank you very much, sir. We look forward to working with you and pushing the board forward. Thank you very much, sir.
I'm insisting that the editor-in-chief should take a picture with the, and yourself, with the new editorial consultants.
Well, as the program draws to a close, I have been given the opportunity to award someone whom I really think that I do not have the pedigree to award. The symposium chairman, the father of the day, a father, a mentor. I think I'll just keep the details inside. Keep the other details. So I would like to present this award of honor on behalf of the Dokita Editorial Board to Professor Temitope Alonge for his exceptional contribution as the chairman of the 52nd Annual Symposium themed Contemporary Threats to Nigeria's Public Health, Infectious Disease, Flooding, and Research Funding Deficits. Please, can we all stand up and applaud our father? Thank you very much.
And now our father of the day will be giving us the closing remarks. Please, round of applause for him.
It's been a long day, and I don't intend to take too long of your time. I want to thank the Vice Chancellor's representative, and I want to thank my brother, Professor Mayowa. I want to sincerely appreciate the Chief Medical Director, ably represented, and all our wonderful speakers. And the audience, thank you for taking time to stay back. Thank you for pointing out the issues that have happened in Ibadan. It's called Ibadan Urban Flood Management Project, which lasted for 13 years, but is rounded up now. But I was telling Professor Ogbole that it's a World Bank project, and what the government has been able to do was to expand the channels that they are pouring all the rubbish into. Otherwise, the flooding in Ibadan would have been worse off. So thank you for the opening our eyes about research, and I want to believe that many of the students are going to be more more interested in research, not only for the money, but also the fact that research is supposed to impact life, and that research is for the general good. And thank you, Ma, for antimicrobial stewardship, which I think I started during my tenure, and I'm glad that you guys have taken it beyond stewardship to antimicrobial resistance screening. Thank you all for being attentive, and I bring greetings from my wife. Today is the 36th wedding anniversary of myself and my wife. And I told her I'm going to spend the better part of it with the Dokita Editorial Board. And so I'm going to give her part of it when I get back home. Probably take her out for a small meal within the compound. So She sends her greetings. Thank you for coming. Even though some of you came for the menu, it is still part of the spirit. Long live the University of Ibadan. Long live the College of Medicine. Long live Dokita Editorial Board. Thank you.
Thank you very much, sir, and congratulations on behalf of everyone here. Can we say congratulations to him, please? Congratulations, sir. We celebrate with you. And so now I'll be calling Ms. Victoria Kolawole, the co-chairman of the symposium, to give the vote of thanks and the closing prayer. Please, round of applause. Just keep clapping until she gets here. Thank you so much.
Standing on existing protocol, I want to thank everybody for coming for this symposium. I really appreciate everybody. I want to thank our guest speakers. I want to thank the chairman. I want to thank all our consultants, heads of departments. Dokita is really grateful. We want to thank all our sponsors. Different people donated for this cause, for this event that is successful, and we are grateful to each and every one of you. Long live Dokita. Thank you. Closing prayer. It's time for the closing prayer. In Jesus' name, the mighty name of Jesus. Lord, we thank you for the 52nd Symposium and 41st Journal launch. We thank you for taking control. We thank you for the success. Accept our thanksgiving in Jesus' name. We pray that as people go back to their places, you be with them, guide them, and direct them in Jesus' name. In Jesus' name we prayed.
Please, can we have all our honorary guests, our special guests, our guests of honor, our past and present editorial consultants? Please, we would like to take a photograph with you. Please come forward. Don't forget to register for up-to-date as you're leaving. Just walk into the library and you can register for up-to-date. Mr. Dairo, join us for the picture. Can all the special guests come forward? Please, let's take a photograph.
Hello, board members, please, can you find a way to the podium now, please? Board members, can you find a way to the podium now for a quick picture? Please, board members, wherever you are, please find a way to the podium now before the light goes off.
The app opened, but it wasn't allowing me to. So send me the account number. So I'll buy 2 copies on behalf of my dad for 50. So send me the account, please. Don't, whenever you have time. Well done. Good job, everyone.
Ma, thank you for staying.
Well, I stayed. I'll leave at 6 a.m. because of you tomorrow.
Thank you so much, Ma.
Congrats. Well done, everyone. Good job. Well done. Don't forget to send me the account. Otherwise, I'll just be thanking God. I keep my money.
I won't forget, Ma. Okay.